मैं लाइव है।
हाँ ठीक है, कोई बात नहीं, हम कॉल पे बात कर लेंगे।
या
तुम
ऑल इज
डाउनलोड कर
लाइव।
लो पहले उस टाइम तक वीडियो।
ऑल लाइव है। Good morning. At the outset, Hi, sir.
Hi, morning.
Good morning,
Bharat.
sir.
How many minutes to go?
See you.
3 more. Mhm.
जब हॉटस्पॉट पे हो क्या कि वाईफाई पे? Because your voice is not smooth. It's coming in bits and pieces.
I'm in hotspot. तो ठीक नहीं है voice?
नहीं नहीं सर, बीच बीच में टूट रहा है.
Oh,
जस्ट मोबाइल का थोड़ा पोजीशन.
अब कुछ better हुआ?
हाँ सर, बेटर है अभी.
Okay. Just give me a signal when we have to start.
Right, sir. So I'll initiate. I'll introduce you, sir, and then you can take over.
Sure, 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 sure.
Manas, let me know when to start.
नहीं
So hi, good morning everyone. Today we are at the last day of this annual conference and it's been a really good initiative by the ICCM, and as we all know, it's been very successful one. We have quite a bit of registrations, and as Dr. Srinivas was talking yesterday, it could be the Guinness World Record as well. The number of people have attended the mechanical ventilation and eco workshops. I'm Dr. Bharat Jagyasi, welcomes you all on behalf of ICCM, and we are going to start this session. I have chairperson Dr. Rajesh Pandey, who's going to chair this session. Sir is known to everyone. He's been mentoring us since long time. He's a general secretary elect as well, and he's a consultant in Gil Kapoor Hospital. Sir, over to you. You can take over the session and introduce the speaker.
Thank you very much, Bharat. Good morning, ladies and gentlemen. And this has been a great by ISCCM team, Dhruv, Deepak, Srinivas Samavedam, Shubhal Dikshit, and all the executive members in difficult times. So, and hearty congratulations to Deepak on taking over as the president of ISCCM. Well, ladies and gentlemen, we have a very exciting session, and in this session, we have a galaxy of speakers like Laurent Brochard, Marvin Singer, Atul Kulkarni, and Praveen Khilnani. So let's start the ball rolling, and we start with the first presentation by Dr. Laurent Brochard, who is very well known in India, and he's affiliated to Keenan Research Center in Canada, and also affiliated with the University of Toronto there. His area of expertise are mechanical ventilation, acute respiratory failure, and respiratory physiology. We have all been listening to his talks and his reading his research papers on ARDS. So, ladies and gentlemen, I present to you Professor Laurent Brochard from Canada.
Thank you very much. It's a pleasure to participate, and I'd like to discuss a topic which really is fascinating, is difficult, and concerns all of us, which is the management of patients with ARDS induced by COVID-19, and what's different from classical ARDS. Whether is there any difference, and if yes, what's different? So I've been working with a number of companies for research grants or equipment. They are listed here. And I will start by a case discussion. I'm sure many of you will feel familiar with this kind of case. So 72-year-old man, obese, based on a relatively high BMI, sleep apnea syndrome at home, but not compliant with CPAP, hypertension. The patient got COVID-19. His wife also, but his wife is less sick. Is admitted for respiratory distress. The chest X-ray is not really impressive, but is very hypoxemic. He's setting 90% using 100% FiO2 with high flow nasal cannula. The respiratory therapist added a venti mask on top of the OptiFlow to be sure he's breathing only oxygen. He did self-proning, and he slightly improved the saturation, not spectacular, but slightly better. But he was tired to stay proning too long. And when you look at him, he has no sign of high work of breathing. His respiratory rate is consistently below 30. He can talk to you easily, and he does not complain of dyspnea, and he understands very well the situation. But the SpO2 continuously drops in the low 80s. He's in the same clinical conditions. So should we intubate this patient or not? Okay, you may have your own decision in your mind, and I'll come back to that. But that's part of the specificity of this COVID-19 respiratory distress, which was called by John Marini and Luciano Gattinoni CARDS. for COVID ARDS. And they try to provide some recommendation which have been debated, and I think the most important one was about the observation made by Luciano Gattinoni that some patients had a surprisingly good compliance compared to the shunt, and this is a very small series of patients, but they show that some patients had good compliance despite a very high shunt, so very hypoxemic, but not the typical alteration in respiratory mechanics. Later on, this is because there has been a lot of correspondence about this issue, and this is a response to correspondence, and saying, well, it may be possible that this is just an issue of timing, that initially the compliance is high and later in the disease the compliance go down. You see the correlation between compliance and time, so it seems to go down. And there's been a lot of debate and series saying, no, we don't see this high compliance, our patients have low compliance. So I think it's a specific disease which we did not see before. What we know now about the typical clinical course regarding the infection, the time of infection and the time of inflammation, is that there's a considerable delay between the inoculation, the peak of infectivity, which may be at the time where there is no symptom, and the time where we see the patient in the ICU, the pulmonary phase, the inflammatory phase, where the viral load can already be low, and this explains that we see a lot of false negative for the PCR, for instance. So at the time we see the patient, there has been already a relatively long disease. And we also have this specific X-ray or CT images with peripheral infiltrates, and sometimes a big dissociation between these images, which do not look so bad, and the hypoxemia, which is very strong. So about the hypoxemia, I think we have tried to look for specific management, which probably is a good thing to do. Self-proning has been, which was known before, but which was rarely used except proning in paralyzed patients, but self-proning was rarely used. And there are reports showing that it may improve oxygenation quite nicely. This is a very reasonable report from Laurent Papazian. You see that some patients improve remarkably their PaO2, but for others it's just a very slight improvement. So it's not a technique which will be a solution for every patient, and it's also limited by the tolerance. Some patients do very well and like it, some other don't like to stay for a long time. The other technique which has been used is high flow nasal cannula. It seems it's a good technique in this indication. They are concerned about the viral dispersion with the technique, which probably is not really much more than when you do nasal prongs or a Venturi mask, and the possibility to add a mask on top of the high flow, I think it's a good solution. But the data we have no randomized trials, suggests that this nice study from France, and they compared, they did a good propensity matching between patients with high flow and with only oxygen. the data suggests you have less patients who receive invasive mechanical ventilation, so you can avoid intubation. They did not see any difference in terms of ICU mortality. So maybe you can avoid some intubation, which is a good thing for the patient, even if you don't change really the outcome. But another really fascinating aspect is what we observe in the case I discussed is this silent hypoxemia or happy hypoxemia. And this is illustrated here in the general population. So you have 3 different individuals, and this is the way they respond in terms of air hunger. So we could say dyspnea, we could say high work of breathing in relationship to their oxygenation. This would be the expired pressure of oxygen. And you see some patients start to react when the PO2, let's say, goes below 80. Most patients will start to react when it's below 60. But some patients do not react until it goes down to around 40. And that's the general population. So what we see in COVID is a lot of patients there not reacting until the PO2 is really very low. We don't know why, and there are suspicions that maybe the carotid bodies, which are supposed to sense the level of hypoxemia, are infected by the virus and are not reacting normally. That's a possibility, but it makes the approach to these patients quite difficult because they're hypoxemic, but they seem to tolerate well, at least in terms of dyspnea. And there are some fascinating results from autopsy studies. So that's, of course, the patients who died with COVID-19, which may give some clue, not about the silent aspect, but about the severity of hypoxemia. What they found is that, so on the left, you have normal vasculature. It's like a cast of the vasculature. And this is what they found in COVID patients. So, and you can see at the bottom some microscopic or electronic microscopic view of the vessels. So they found some thrombosis and microthrombosis, but they also found this new neoangiogenesis. So it's like new vessels. And this was described even better in this paper in the European Respiratory Journal. And they show that the infection with the virus could result in this generation of new vessels in situ. So instead of, one single vessel which could go to one single alveoli, if you wish, you may have multiple vessels. And this may explain that we see a lot of hypoxemia, even if the lung parenchyma is not so damaged. This may explain high levels of shunt. And this may also explain that part of these vessels may not be great and you have more microthrombosis in these vessels. So this looks really specific to this disease. And then comes the question for the clinician, what should we do? And Martin Tobin has been one of the first saying, well, we have these patients with silent hypoxemia. They exhibit little dyspnea or distress. And you have to remember a number of things. First, humans do not typically experience dyspnea until it goes down to 60, usually. Second, the SpO2 reading is not very good when you have you are in low values. It can exaggerate the value. And these patients may also have a number of comorbidities which may explain the blunt response to hypoxemia. But his recommendation was to say we should wait and intubate these patients only if they develop respiratory distress. And it makes sense. On the other hand, as I've shown you, we see these patients at a late stage, and in some places, and I'm sure it happens in many centers across the world, you can see these patients at a very late stage. These are patients from Peru, and you probably know Peru at one time was one of the most affected country per inhabitant, and this is X-ray from patients in the ICU where roll in, roll down is ICU physician working there. And he had these patients who arrived with already a terrible disease. And as you can see, when he put these patients under mechanical ventilation, you see the pressure, the plateau is at 28, but the PEEP is only 4. The driving pressure is 24. The compliance is extremely low. And of course, you wonder whether maybe they have been intubated too late and they developed some self-inflicted lung injury. So really difficult question. We know it's possible in general that you have, lung edema, you impair gas exchange and mechanics, these increase the respiratory drive, which create negative alveolar pressure, which create pendeluft in the distribution of volume and increase the stress on the lung. And this can induce self-inflicted lung injury. But of course, for that, you need to have this increased respiratory drive, which may not be present in every patient. And we know it may happen. This is an example specific to COVID patients where patients were initially intubated, sedated, and then they woke up, they were switched to pressure support. But some of them worsen, relapse, if you wish. So they compare the patients who relapse and the patients who did not relapse. And they measure a very simple index of respiratory drive, which is available on ventilators, which is the occlusion pressure of P01. And you see, there is some overlap between the two groups, but in general, the patients who had this relapse were the patients with high respiratory drive. So it does not mean that it's a proof that they have self-inflicted lung injury, but that when the drive is high, troubles may happen, and it's probably better to lower the drive and go back to controlled ventilation. There had been discussion about the ventilatory ratio as a specific aspect of dead space and high dead space in these patients. I just would like to be cautious about that, because the ventilatory ratio is the ratio of the product of PCO2 and minute ventilation for if you take normal values to the actual so the actual values ratio to the normal values, and the higher this ratio, the higher is the dead space. However, this ratio is very much influenced by the settings you adjust on the ventilator, the tidal volume, the rate, etc. And we know in general, if you look at the relationship between tidal volume and respiratory rate, so this curve represents a given minute ventilation. This is the type of curves you have in the operating room, so in patients with normal lungs. So the minute ventilation is around 100 ml per kilogram per minute. But in ARDS patient in general, we know it's higher. It's about 150. That's data from ARDS studies. So there is no novelty here compared to classical ARDS. In addition, if on top of that you add a filter, an heat and moisture exchanging filter, for the purpose of additional protection from the dispersion of the virus, you may considerably increase this curve. So you may increase the total minute ventilation because you add external dead space. So just a note of caution, because many of the findings about high dead space and high ventilatory ratio, to my sense, were due to these different ways of humidification and filtration. What about the lung recruitability? Well, we know from classical ARDS that some patients are recruiter, some patients are not recruiter. What does it mean, recruiter? It means that there are areas of the lung which would be closed, can be reopened under pressure, and can be kept open. That's what we have in mind when we say we recruit the lung. And this is a good example because this is not a clinical situation, really. This is when you go from 5 to 45 centimeters of water. On the right, you see that you reopen part of the lung, right? We don't know if it will be kept open when you go down, but at least you reopen part of the lung. But the other patient, the non-recruiter, if you look at the densities, it's almost the same from 5 to 45. So to be simple, I would say the non-recruiter, the pressure is useless. It does not reopen the lung. The recruiter, yes, it is useful because it reopens the lung. In addition, it's very interesting to look at the size of the heart. You see how the heart is squeezed in the non-recruiter, which is not the case in recruiter. So maybe it's really important to know who is non-recruitable because the pressure is useless and maybe harmful. So maybe there are a lot of patients where you do not need to go higher on the PEEP. At the bedside, we have potentially two techniques. I won't go into details. This is one interesting technique because it's imaging technique at the bedside, electrical impedance tomography. Just want to show you what we usually see in patient supine. You see that the dependent part of the lung is not ventilated. And when you increase the PEEP, you recruit this part of the lung. What we found really interesting with this technique is that sometimes you may see that you ventilate predominantly the dependent part. Oh, how is that possible? Well, there is only one explanation, is that you now are over distending the non-dependent part. And that's really the problem with PEEP, right? Recruitment on one side, distension on the other side. And we found this technique could help to find the balance. And for instance, we found that when we see that, it's an incentive to decrease PEEP. So this technique has been used in COVID patients, but again, the problem is where do you put the cutoff for the amount of recruitment versus the amount of distension. So in this study, they focused mostly on minimizing the collapse, which is the orange curve when you go from a PEEP of 30 to 10. And therefore they selected relatively high PEEP. We designed a technique which I encourage you to learn because it's a technique which can be used on any ventilator, which is the measurement of what we call the recruitment to inflation ratio. So it's based on the hysteresis behavior of the lung. When you increase PEEP and you recruit the lung, your PV curve will be shifted upward, which means you will have the same pressure with higher volume in the system. So it's really the definition of mechanical recruitment. And the way we do that is we just decrease the PEEP from one level to the other. So we induce de-recruitment if you wish. We usually go from 15 to 5, so it's a delta PEEP of 10 in one breath. And then you measured, and this is displayed on the ventilator, the expired volume. We subtract the inspired volume, and therefore we have the exact volume which is trapped by PEEP from 15 to 5. and we compare this trapped volume to the volume which was predicted by the compliance at low PEEP. Let me show you how we do it in 1 minute. Okay, so that's it. This is a very simple maneuver. The patient needs to be relaxed. You need to make the measurement in this order. So decrease the frequency, drop the PEEP, measure the tidal volume, measure the compliance at low PEEP, and then you go back to the initial setting. And then you know if your patient is more on the recruitable side or the non-recruitable. And so we assess the part of the volume which will go into the recruitment of the lung versus the part which will be only inflating the baby lung. And this index has been used in COVID patients. And you can see here an example from the very first patients in Wuhan at the time of when the virus was still mostly in China. And you see they measured the recruitability index. When it's below 0.5, it's usually indicating that the patient is not recruitable. And there are a lot of patients who were not recruitable, so where PEEP was probably not indicated more than 8 to 10 centimeters of water. Interestingly, they prone a number of patients, and if you look at the index, so this is after proning, for instance, it frequently increased after proning, suggesting that prone may not be only a good technique for protecting the lung and improving oxygenation, but also for making the lung more recruitable. This is a study which we did with colleagues in Rome. They match very precisely for the same oxygenation value and PEEP and FiO2, patients with COVID and non-COVID. And when you compare the two groups, so COVID and non-COVID, well, you see a significantly higher compliance in COVID. So again, trying to confirm what was shown by Gattinoni initially, that there is a signal indicating for the same hypoxemia, the lung is a bit less injured, and especially when you go for compliance per predicted body weight, which kind of normalized to the lung height. But in terms of recruitability, there was no difference between COVID and non-COVID, and the point is that the values go all over the place. You have patients completely non-recruitable and patients who are very highly recruitable. So you really need to individualize the data. This is a very recent study from Giacomo Grasselli and the group in Italy. A lot of patients. Interestingly, the COVID patients had more severe hypoxemia, so severe ARDS. But again, despite being more hypoxemic, their compliance was slightly higher. So there is clearly something specific to this disease. And why so many studies did not find a difference between COVID and non-COVID, especially when it was small studies, I guess that once the patient is intubated, sedated, paralyzed, supine, a lot of these factors worsen the atelectasis and make the patients looking more like a classical ARDS. So remember, this was the case I presented initially. Very nice patient, not looking in distress, but really setting very low, with repeated drops in saturation below the 80s. So everybody was concerned, and at some point there was a trial of non-invasive ventilation. He tolerated that well, but he also was taking large tidal volumes, and clinicians decided to go for intubation. So honestly, I don't know if it was a good solution or not. These patients could suffer from severe hypoxemia and maybe start to have coronary ischemia or gut ischemia or other things. So maybe intubation was indicated, but I would really wait as much as possible if these patients have no distress. And unfortunately, the outcome of this patient has not been good. So this is a complicated situation. This is a new disease, I think, and really we are learning every day about how to manage these patients. I would say conservatively as much as possible if they have no distress. Later on, they may develop high respiratory drive, and the risk of self-inflicted lung injury exists. But really, it's a matter of individualizing the best treatment for every patient. If you're interested to continue this kind of discussion, please visit our blog, which is Center of Excellence in Mechanical Ventilation, COEMV.ca, and we'll be happy to share with you our stories and discuss our latest findings. Thank you very much.
Thank you very much, Dr. Laurent Brochard, for a very illustrative talk on COVID-19, what's different, and also demonstrating your method of knowing about the recruitability of the lung. We move on to the next talk, which is by Dr. Marvin Singer. Again, he is no stranger to India, and he is professor of intensive care medicine. His areas of expertise include sepsis, shock monitoring, and hemodynamics. He is affiliated to the University College London, and he was responsible for Sepsis 3, as we know, and also the International Sepsis Forum. So Dr. Marvin Singer will be talking about cytokine storm. Is it a reality or more of a breeze? Over to you, Dr. Marvin Singer. We'll have question answer at the end of the session.
Hi, and thank you very much for the invitation to speak at your lovely Congress. What I'm going to talk to you about today is COVID-19. Is it a cytokine storm or maybe just a breeze? That don't know me, I'm Professor of Intensive Care at University College London. This beautiful red brick Victorian Gothic building used to be the old hospital, and now it's a medical school series of laboratories and lecture theatres, and that's where I have my lab. And the blue, green and white building behind with the tower block is the new hospital. I led the task force coming up with the Sepsis 3 definitions, and I've recently stepped down as chair of the International Sepsis Forum. I have a big research interest in sepsis, and it goes from mechanistic through to translational through to clinical studies. I'd like to start talking about COVID, but making a comparison against standard bacterial sepsis. I'll enlarge upon this later, but this is a simple table that just makes a broad comparison. So COVID-19 is indeed sepsis when the patient becomes sick enough to get to intensive care. So the patient has an infection, in this case the SARS-CoV-2 virus, and that triggers organ dysfunction predominantly lung function, which brings the patient into intensive care. However, there are quite marked differences between a COVID patient and a standard bacterial septic patient who comes in through the emergency department. So the immune system is generally far more activated in bacterial sepsis, and the cytokine response, as I'll show you later, is far greater. There's more endothelial activation, but perhaps less of an acute phase response in COVID, or in bacterial sepsis as opposed to COVID. The degree of thrombopathy, so that is the mechanisms leading to pulmonary emboli, deep vein thrombosis, is greater with COVID, but you see much more of a coagulopathy, abnormal prothrombin time, low platelets, etc., with a bacterial sepsis. And the degree of multi-organ failure is much greater with bacterial sepsis. COVID, when the patient presents, it's usually predominantly single organ lung failure. Other organs tend to fail, I would argue, more as an iatrogenic complication. Over-sedation drops the blood pressure, results in renal dysfunction, etc. So I think there are big differences between COVID and the standard bacterial septic hit. However, this concept of cytokine storm has been driven by lots of emotive headlines in newspapers and journals, and you see here a few publications. The third one down, COVID-19 cytokine storm, the anger of inflammation. And this has fueled lots of enthusiasm from drug companies, from academic groups, to target not just the virus with antiviral therapies, but a whole variety of drugs or other techniques targeted against cytokines and other mediators. Most of these studies have been targeted either against interleukin-1 with the use of anakinra or anti-interleukin-6 treatments such as tocilizumab and sariluzumab, and these block the receptor that interleukin-6 binds to. However, is the cytokine storm relevant to COVID-19? And a number of papers have come out actually showing it's not particularly relevant. So this is a comparison from Sinha and colleagues from San Francisco, looking at what's been published at the time for COVID-19 and comparing it against similar results measured in ARDS trials. And you'll see here they looked at interleukin-6 levels, and in the ARDS trials they had the so-called hypo-inflammatory phenotype. So these people were inflamed, but not so much as the hyper-inflammatory phenotype. So if we focus on COVID-19 papers, the severe disease gave relatively low interleukin-6 levels. They were normal or only moderately raised above the normal range. Whereas if you look at both the hypo and the hyperinflammatory phenotypes of ARDS, they're far higher. They're on average about 1 to 2 log orders higher than seen in COVID. But this was known right at the very beginning. This is one of the earliest publications from Wuhan in China, and they, in this paper, looked at various cytokines, and they compared the levels in healthy controls, patients who required intensive care, and patients who didn't require intensive care. And as you'll see, there are marginal differences, and they are statistically significant, but the levels are not particularly high in the COVID patients, and in most of the cases there's very little difference in cytokine levels between those requiring intensive care and those not requiring intensive care. And then papers started appearing. This is from Guillaume Monneret from France, where they looked at interleukin-6 levels against what had been previously published in septic shock and in cytokine release syndrome. So that's when for example, CAR T therapies given to cancer patients that can induce a cytokine storm. And you can see the y-axis is a logarithmic scale. You've got a 1 log order difference in septic shock and a 2 to 3 log order difference in cytokine storm. This nice systematic review came out from Cliff Deutschmann's group in America, and you'll see along the x-axis, severe COVID, critical COVID, all COVID, the levels of interleukin-6 were very, very low. In the ARDS groups, the papers that had been published, they were higher, and in all ARDS, in sepsis, highest, and the CRS, the cytokine release syndrome, higher still. So again, it doesn't look like a cytokine storm. And they also measured a whole variety of, or looked at papers that had measured a whole variety of other cytokines. Inflammatory cytokines such as interleukin-6, TNF-alpha, and anti-inflammatory cytokines like interleukin-10. So in these graphs, the light blue and the dark blue dots relate to the COVID patients, and the others relate to ARDS or septic patients and patients with cytokine release syndrome. And the same message is seen. You see a much bigger response in septic patients and an even greater response, both in terms of the pro and the anti-inflammatory cytokine response in patients with cytokine release syndrome as a complication of cancer therapy. This is data we're just about to publish. I'll just show a few snippets. Nisharul Kumaran is the senior author. And we managed to get samples from healthy volunteers, people who were infected but asymptomatic. This was a screening trial, so we got samples there. Patients who were admitted to hospital but only had mild illness, patients who needed critical care, and a separate group, we had the patients who ended up dying. And very interestingly, you can see the TNF-alpha levels, shown on the left, were actually highest in the asymptomatic non-infected group. The levels fell thereafter and were actually significantly lower than healthy people. For interleukin-1, a very similar picture. They were very low in the patients who needed hospitalization. Interleukin-6, the levels were a bit higher, but even in the asymptomatic patients, they were actually higher still. And for interleukin-10, again, slightly higher in those people who went on to die or needed intensive care compared to those who had mild disease. There were some cytokines where we found differences, but these were generally suppressed. So I'm showing here as a few examples: interleukin-5, interleukin-12, interleukin-8, which are responsible, for, T cell maturation, monocytes, activation, etc. So these are actually suppressed. So there's this overall immune suppression that we're seeing. On the other hand, IP10, and this is a chemokine, which is an attractant for T cells, for monocytes, and it's stimulated by interferon beta, does go up and rises with increasing severity. So, as a concluding part to this, is COVID-19 actually a hyperinflammatory condition? Yes, it is, but they're not particularly hyperinflammatory. So we can't really say, in terms of a cytokine response, that they do fulfill that criteria or the tag, the label of a cytokine storm. I think, though, it is fair to say that there is a very robust acute phase response during COVID. And if you look at a whole variety of different acute phase reactants, mainly produced by the liver, many of these are published and shown to be elevated in COVID. There are other acute phase reactants that haven't been measured to my knowledge. And going back to the paper in Lancet Respiratory Medicine from the Deutschmann group, Again, they looked at acute phase reactants and a similar pattern was seen. So COVID went up, or the levels went up for CRP, ferritin, LDH, D-dimers, and procalcitonin. However, these were nowhere near the levels seen in septic patients, or especially cytokine release syndrome. So there are disparities. So D-dimers were generally higher in COVID patients, PCT, procalcitonin, higher in septic patients, LDH very high in patients with cytokine release syndrome, as was ferritin, and the CRP higher by and large in the septic patients. There's this nice summary picture in this paper comparing the COVID-19 response with a standard ARDS response with septic patients and with this cytokine release syndrome induced by CAR T therapy. And I'll leave you to get the paper, but you can see where they've indicated that depending on the condition, cytokines go up or down, acute phase reactants are more or less stimulated. So then we have an important question. If there isn't a cytokine storm, why has tocilizumab, an interleukin-6 receptor agonist, shown mortality benefit in both the recovery and the REMAP-CAP studies? I'll focus on recovery because it was a far bigger trial, and this is at the moment only available as a preprint, so we haven't seen the full paper, but you can see there was overall an effect of tocilizumab on mortality and patients discharged alive from hospital. However, I would stress this stops at 28 days, and we know many intensive care patients require a much longer stay than 28 days. And so, you know, about a quarter of the patients were still in hospital at that 28-day mark, so we don't know the final outcomes. However, intriguingly, when you look at the subset analyses, you don't see a consistent picture. So age, in patients who received it who are over 80, there was no benefit at all. It only seemed to work. The odds ratio was shifted to the left, tocilizumab being better in younger populations. In terms of sex, there was no benefit seen in women. The benefit was only seen in men. If you look at ethnicity, there was no effect in the so-called BAME population, Black, Asian, minority, ethnic, or where patients were unknown, but the benefit was seen in white populations, Caucasian populations. When you look at when the patient was randomized into the trial, there was no benefit if they were on invasive mechanical ventilation. The benefit was seen if the drug was given earlier. And there was no benefit if corticosteroids weren't given. There seems to be a synergy if there was ongoing or concurrent steroids. So when we come back to that question, why has it shown an overall mortality benefit? Well, clearly because more men get COVID, about 70%, compared to about 30% of patient populations who are female. The simple answer is, I don't know. I can speculate that maybe there's a higher lung localized interleukin-6 response that doesn't spill over into the blood. So we don't see very high systemic levels, but it may be within the lung, and perhaps the drug is having an effect there. We don't see, as I mentioned earlier, much in the way of multi-organ failure, septic shock, etc. with COVID. So maybe, therefore, we don't see the systemic response and thus measure the very high levels in the blood. But as I made the point before, it may be present at higher levels in the lung. Of note, and this is a bit worrying, this is now seen widespread across the UK. In the second surge, there's obviously been a lot more use of steroids and tocilizumab. The recovery trial was done in the UK, but we're not seeing any clear benefit. But what we are seeing is a lot more secondary bacterial and fungal infection. So I think the story is still very confusing, and I just don't know the answer. So in summary, hopefully I've convinced you that we don't see a systemic cytokine storm in COVID, but more of a cytokine breeze. The cytokine levels, both pro and anti, are sometimes elevated, but if so, it's fairly mild, or no change from healthy controls, or even suppressed. And there's no overall strong relationship to outcome. With interleukin-6, there are differences, but as I mentioned before, the levels aren't particularly high. And going back to that breakdown I showed you on the recovery trial, why should the drug save lives in pale and not so stale males, but not seem to help women, Black and Asian minority ethnic or elderly patients? So we have many, many, many questions left to answer. On that note, I'll finish, and thank you very much indeed for listening.
Thank you very much, Dr. Marvin Singer, for a very illuminating talk, and you probably have changed the way we were looking at the cytokine storm in COVID-19. It still remains an enigma, as you have highlighted. There are many, many questions which are still unanswered. Thank you very much. So, ladies and gentlemen, we now move on to the next plenary lecture, which is by Dr. Atul Kulkarni. And Atul, we know very well, he has been a force to reckon with and has been instrumental in building up the ISCCM. So he's the one who knows everything and most about the ISCCM history and the laws. He is currently Professor and Head Division of Critical Care Medicine, Department of Anesthesiology, Critical Care Pain at the Tata Memorial Hospital, Mumbai. And he's also the Editor-in-Chief of Indian Journal of Critical Care Medicine. And we have seen a significant metamorphosis in the journal, all for the good. And I think in 5 years, we'll be one of the highly rated peer-reviewed journals in critical care. And of course, we all know that he has been a past president of Indian Society of Critical Care, past chancellor of the college. So ladies and gentlemen, I give you Dr. Atul Kulkarni, who will be talking about publications during pandemic, what to watch out. Dr. Kulkarni, please.
Good morning. At the outset, I would like to take this opportunity to thank Dr. Chaudhary, Dr. Goyal, and Dr. Srinivas Samvedan for giving me this opportunity to speak on an offbeat topic, publications during pandemic, what to watch out for. I'll be talking about the beginning of EBM, how it translates into our clinical practice, what are the problems that were created in the pandemic era, and how it affected the practice of EBM. There have been a lot of publications, so I will be restricting myself to only the hydroxychloroquine debacle and the remdesivir saga. And then I will come to what and how should I read, what to watch out for, and ultimately the most important part, what should I do at the bedside. So in 1995, Sackett and colleagues defined evidence-based medicine as the conscientious, explicit, and judicious use of current-based evidence in making decisions about the care of individual patients. And they suggested that evidence-based medicine rested on the three pillars: the published evidence, the clinical judgment, and the expertise, and the patient values and preferences. Initially, EBM was made fun of. A lot of satire was published at that time. For example, this paper said there are 7 alternatives to evidence-based medicine, such as eminence-based medicine, vehemence-based medicine, eloquence-based medicine, and confidence-based medicine. And they defined each of those in a hilarious manner. Another interesting commentary depicted a dialogue between Socrates and what he called as his trainee, Enthusiasticus, about the evidence-based medicine. And here, Enthusiasticus is explaining to Socrates what is this new form of medical practice. And he tells him that this is very interesting and it seems to work, and we call it evidence-based medicine. There are multiple difficulties in adopting EBM because people think that EBM to clinical based decision making rests on the assumption that clinical observation is totally objective and it's always reproducible, which is not the case. Different people examining the same patient might make different clinical observations. As late as 2018, this paper was published, which suggested that there are many barriers to implementing EBM interventions in the current scenario, and they published a systematic review about it. And some of these are common to us in our practice, which are now worsened by the presence of pandemic, such as lack of financial resources, lack of staff resources, lack of time, insufficient space for all services. The second barrier consists of delivery capability, and this is particularly true in resource limited settings, such as difficulties in implementation, lack of expertise or experience, lack of administrative infrastructure, and cultural barriers. So whenever a new intervention is described for a new illness, the intervention is generally based on pathophysiology and biological plausibility. So the intervention is suggested, then animal studies are carried out. If these studies are successful, then human studies testing the intervention for efficacy and safety occur. This is followed by randomized clinical trial. And if this is also positive, then more RCTs are carried out to see if these results are reproducible. Ultimately, a lot of literature is generated, systematic reviews and meta-analysis are published. And then, after a lot of time is gone by, the new intervention is decided to either have no effect or have benefit for the patient. In some instances, it can actually harm the patient. It has been 25 years since EBM was first described, and it is here to stay. However, with SARS-CoV-2 coming into the world, the EBM lay in ruins because there was no published evidence, we had not seen it before, and therefore we had no clinical judgment to offer. What this did was it led to marked escalation in journal submissions during the COVID-19 pandemic. And this is data from the Annals of Emergency Medicine Journal. And you can see that as soon as the pandemic started, there has been a big jump in submissions for publication in this journal. And same is the true story for most of the other journals. This paper looked at the number of papers that were published in those 3 months. And you can see there have been a lot of commentaries, narrative reviews, editorials, etc., but only 4 randomized controlled trials. Because everybody wanted to publish, sometimes the authors, sometimes the editors, sometimes the reviewers got it wrong, and this has led to an alarming retraction rate for scientific publications on coronavirus disease. So this, the authors compared to other pandemics or epidemics such as Ebola, H1N1, HIV, or MERS. Nobody thought that this pandemic can be or is going to be this bad, but it is certainly much, much worse than any of the preceding pandemics. And this retraction rate might look very small, but just compare it with the previous retraction rates and it assumes great significance. So there was a hammering article written by Professor Gale, who suggested that are we planning to conquest the COVID-19 by publishing it to death? This is true because there is a rat race for publications in today's world. So when the first paper on EBM was published, one gentleman calculated how many articles someone practicing adult internal medicine had to read daily to keep in touch with the current evidence. So if you were a dedicated doctor, you would need to read at least 17 articles per day, every day of the year, throughout the year without taking a break to keep abreast of the new developments in the field. Back to the future, I searched the PubMed, and this was some time back. In 1 year, we had more than 100,000 publications on COVID-19 alone. So I just put a search term COVID-19, and this is the number of publications that I got. It is impossible to read these many manuscripts and make sense of them. So what should I read and when do I read? And what do I do for the patient is a burning question for all of us. So remember that I said we made fun of EBM, and the alternatives suggested were various types of immunons, vehemence, etc. based practices for medicine. But did we repeat the mistakes? Look at the hydroxychloroquine fiasco. Everybody is familiar with this gentleman. He was an eminent French scientist, made a lot of noise about hydroxychloroquine use and azithromycin use for treatment of COVID-19. He's quite well spoken of and is a very, very glib speaker, and he is very, very confident. The matters were made worse when the politicians joined him into promoting hydroxychloroquine and azithromycin. So when we teach our students how to read a paper, this is what we are supposed to do. You look at the journal name and how reputed the journal is and its impact factor. Then you look at the level of evidence, what type of manuscript it is, and then look at the pedigree of the author and their working group. So look at this paper. This paper was published very, very early in the course of the disease. This was e-published on March 20, International Journal of Antimicrobial Agents, which is a reasonably good journal, good impact factor, well-known group of authors. Didier Raoult has over 2,300 citations, but it was an open label, non-randomized trial, which is as low as you can go when you consider the level of evidence. And what is the conclusion? Despite its small size, they said hydroxychloroquine treatment is significantly associated with reduction in viral load. And this effect is reinforced by use of azithromycin. This paper was severely criticized, and some of the criticism was about the timelines. So the trial was approved on 5th March by the drug safety. Then it was approved by ethics committee on the 6th March. The paper said the patients were followed up till day 14, but the paper doesn't actually show any data for day 14. So if the study was started on say 7th March, the paper was submitted for publication on March 16, how it is possible that it can have a 14-day timeline? And on 20th March, it was already published. Because of all this flag, the International Society of Antimicrobial Chemotherapy published an expression of concern. Which said that there were some suggestions online about the reliability of the peer review process. The chief editor was one of the authors in the paper, and they said that the journal did adhere to the peer review rules and the author had no involvement in the process of peer review. After publication of this paper and the level of strategy shown by Professor Raoult, the French President Macron went and met him. There was an online petition signed by over 400,000 Frenchmen, and this made the matter worse. Subsequently, there were two papers published by an American analytical group called Surgispear about hydroxychloroquine or chloroquine with or without macrolide for treatment of COVID-19. One was published in Lancet, a very, very reputed journal. The reason given for retraction was that the Surgispear could not transfer the full dataset, citing the reason that it would violate their client and confidentiality agreement. Since independent peer review of the data was not possible, the independent group withdrew from the peer review process, and therefore the journal was compelled to retract this paper. The same group published another paper in the New England Journal of Medicine, which was again retracted, where the reason cited again was that there was no access to the raw data, and the authors themselves retracted this article. Last week, a meta-analysis was published in the Cochrane Library on chloroquine and hydroxychloroquine for prevention and treatment of COVID-19. And this was final nail in the coffin of this mode of treatment for COVID-19. They concluded that hydroxychloroquine for COVID-19 has little or no effect on the risk of death or progression to mechanical ventilation, though the adverse effects were 3 times higher. Most of them were not serious. Let us come to the remdesivir saga now. The first paper about remdesivir was published in April, I think. This was a double-blind, placebo-controlled, multi-center trial published in Lancet. And in conclusion, the author stated that remdesivir was not associated with statistically significant clinical benefits, but there was some time reduction in time to clinical improvement. However, they suggested that we need confirmation in larger studies. As soon as this was published, the US FDA issued an emergency use authorization. And what did the FDA notice say? It said the investigational drug was shown in a clinical trial to shorten the time to recovery in some patients. So not a very strong reason. Maybe the pharma played a big role. The second trial about remdesivir was published, which compared a 5-day course to a 10-day course. There was no difference whether a 5-day or 10-day course was given. Much later, this trial was published in New England Journal of Medicine, remdesivir for treatment of COVID-19, which concluded that remdesivir was superior to placebo in shortening the time to recovery in adult patients who had evidence of low respiratory tract infection. Let us look at this in some detail. So there was very complicated analysis and discussion. The forest graph is very, very conclusive, which I will show you in a minute. The authors say in discussion that the primary and secondary endpoints were interchanged. And in discussion, they also say that treating the patient of COVID-19 with remdesivir alone may not be enough. Look at this forest graph, and I am going to show you a particular area here. All the effect is going across the line of unity, which essentially means that you cannot say whether placebo is better or remdesivir is better. There seems to be some effect in patients who are receiving oxygen, where remdesivir is better. But again, the endpoint is time to clinical recovery and not improvement in mortality. A very interesting note at the footnote at the bottom of this forest plot. The width of the confidence intervals have not been adjusted for multiplicity, etc., which is generally not done in any publication. So was it time to despair? Does anything work at all? The Leeds teaching hospitals under NHS had this platform called REMAP-CAP, which is an international randomized controlled trial looking at the effect of different drugs in patients who had community-acquired pneumonia. And their first trial was published looking at the effect of steroids, in particular hydrocortisone, on mortality and organ support in patients with severe COVID-19. They used an innovative trial design, which is called ongoing adaptive platform. And they showed that patients who did not receive hydrocortisone had less organ support free days as compared to those who received either shock dependent doses of hydrocortisone or fixed dose hydrocortisone. The proportion of patients who were given hydrocortisone similarly had more chances of having organ support free days. So either a 7-day fixed course or shock dependent dosing of hydrocortisone resulted in 93% and 80% probability of superiority in improvement in organ support free days at 21 days in patients who had severe COVID-19. So coming to the question, what literature should I read and how do I change my practice? So I would suggest that we should continue to read high impact journals. They are likely to get things right more often than not. Only notable examples have been those Lancet and New England Journal of Medicine papers. When you read the journal or you read a paper, do not take the results of a study at face value and don't adapt anything instantly. Wait, there might be a retraction coming soon. Look for corroborative evidence if possible. If of interest, read the full article, not just the abstract. Remember the remdesivir, the final report paper, the abstract says that in conclusion that remdesivir seems to work, but you read the full paper, you find out there are a lot many fallacies in the paper and the authors have not stated the conclusion properly. If the results are too good to be true, then they are probably not true. Wait for confirmation from another author group, wait for some time to get proper results. If the results are too good or too bad, both are unlikely. Truth is always somewhere in between. So wait, don't hurry. Always read the accompanying editorial. It often explains the fallacies of the methodology, the discussion and the results. Same thing with comments. And the letters will often criticize either the method or the discussion or the endpoints. So always read these and never ever read only the abstract. What should I do at the bedside? First, principle should be primum non nocere. First, do no harm. Most important, and the senior people in ICE system have always been telling all of us this, do not forget the basic tenets of critical care. When you are very enthusiastic about adopting the latest drugs and techniques, just having biological plausibility is not enough justification to administer a drug to a critically ill patient outside of a clinical trial. So yes, if there is a biological plausibility, maybe you should start a clinical trial and use the drug in that instance. And a classic example of this is what we discussed earlier. Remember, many of the experimental agents may have pharmacological interactions with the drugs that are commonly used in the critically ill patients, which may produce unknown harms, which we will not know at the time of starting of these drugs. All patients are different, and therefore treating all patients with the same therapy regardless of stage of disease or clinical phenotype is different. For example, someone who doesn't have a cytokine storm should not be given immunomodulation treatment. Someone who has high compliance ARDS should be treated differently from one who has low compliance ARDS. Pharmacologic management should be individualized. For example, in terms of viral phase of viral replication, or in case you get an inadequate post response. If there are therapies which are unproven, don't use them, because the clinical equipoise is lost and you lose a chance of doing or carrying out a randomized control trial. And because this agent, because it is being used constantly, that becomes the de facto standard of care. Thank you very much.
Thank you very much, Dr. Atul. This was a very, very interesting talk, and I really loved your talk. You made a great point, and I'm sure all the PGs and fellows who are watching this program, they are highly impressed and they would follow the right path. And particularly the point that you made, a physiological logic does not translate into using the drug. It really calls for doing an RCT or a trial. So thank you very much, and we'll have questions at the end of the session. We are running a bit early, so we'll have plenty of time. Please stay with us. So to take it further, we have our next speaker, none other than Dr. Praveen Khilnani, who is very well known in critical care circles in India. And he is the director of PICU and Rainbow Group Head Academics. He's Vice Chancellor of Indian Association of Pediatrics, ICC College of Pediatric Critical Care. He's American Board Certification in Pediatrics and Critical Care, and currently affiliated with Rainbow Children's Hospital. And he was ISCCM Chairperson for Delhi from 2011 to 13, and possibly he's the only MCCM awardee by American College of Critical Care Medicine in India. He has a lot of publications, and he's very well known in pediatric circles and also in the adult circles. So, ladies and gentlemen, I present to you Dr. Praveen Khilnani, who will be talking on a very interesting aspect, 10 commandments for new critical care fellows. Dr. Khilnani, please.
Good evening. I'm Dr. Praveen Khilnani. I'm currently the Director of Pediatric Critical Care Unit at Rainbow Children's Hospital, New Delhi. And I'm also the Group Academic Director for Rainbow Group of the Hospitals, India. I've been a Vice Chancellor, Indian Academy of Pediatric Intensive Care Chapter, College Council. The topic for today in the discussion for the Critic Care 2021 is 10 Commandments for New Fellows. Now, these fellows are intensive care fellows, Indian Diploma of Critical Care Medicine, Indian Diploma of Pediatric Critical Care Medicine. The commandments are essentially, these are sort of new orientation for what should a fellow expect and what is expected of the new intensive care fellow. So the fellow has joined in to become an intensivist. And the term intensivist itself implies an intensive management. In modern ICUs, the primary focus is on complex technology and electronic health records, often away from the bedside. And excess interventionism is the norm. And the caution being that this strategy can lead us away from a patient-centered practice and towards iatrogenic harm. Now, in the words of William Osler, the good physician treats the disease, the great physician treats the patient who has the disease. Now, medicine and philosophy, they do sort of interact in intensive care. The evidence-based medicine asks us to integrate the best available evidence with clinical experience and patient values. So first, do no harm. And remember ICU killers. If you lose an airway, if there is high potassium, if there is a vasoactive infusion syringe change disconnect, fast IV push of potassium chloride, unstable arrhythmias, decimal errors, and the wrong drug labels. So if you look at all of these killers, look at how low is the primary condition which is killing. It is the iatrogenic, many of the errors that cause this problem. And that's the reason why we have put up this lecture for the newer fellows to first do no harm and ensure that all the good things are done to the patient to make the patient better. So concept of Zen-tensivist is a new thing. The term Zen-tensivist intentionally combines concepts seemingly at odds, Zen philosophy and intensive care, to describe a holistic approach to the art of caring for the critically ill. So what is Zen philosophy? Stripped down, determined, and practice-oriented care. That's what Zen philosophy is. And the disclaimer is that the usage of Zen philosophy is not intended towards any particular religion or spiritual beliefs. So Zen philosophy and intensivist philosophy need to be amalgamated to get the holistic approach. So under the hashtag Zen-tensivist, an intentional practicing multi-specialty group of clinicians has begun of Zen-tensivist. So where you look at history taking, physical examination, physiology, pharmacology, and clinical research in a competent, compassionate, and minimalist fashion. I've underlined the word minimalist is that you do the minimum possible thing and not do too much of intervention. Okay, whatever is the minimal possible thing, reasonable to get the patient better. So if you look at in ICU, you will see the grounded, evidence-based therapy, tincture, time, Zen-tensivist, kindness, less is more, directed, calm, compassionate. So it's a whole jumble of things, and you have to choose what exactly does your patient need. So do all patient parameters need to be directed towards normal values? Probably not. Ebereg and O'Brien have cautioned against the normalization heuristic that is pervasive in medicine. Accordingly, the Zen-tensivist stands back and watches the interaction of external factors with human physiology indexing the outcome with common sense. So parameter examples, fever, hyperglycemia, or chronic electrolyte disturbances the available evidence does not support an interventionist approach to restore normality. Permissive hypercapnia in the acute respiratory distress syndrome. The abnormality is plausibility protective to lung. So just imagine, God has made many of these physiological, pathophysiological responses to protect the patient, and you don't want to necessarily take away those parameters to try to bring them to normalcy. So what does all that mean to a new fellow? And I'll just talk about key points, the 10 commandments for new fellows who are aspiring to be intensivist, or let's say Zentensivist. So, first commandment, get into the speed. Have an intensivist eye, have an intensivist speed. That means oxygen therapy, securing the airway, ensuring breathing, fluid bolus, and or CPR as the case may be, but do it fast. Do it with an intensivist speed by using your intensivist eye to quickly determine a sick patient. So respect these golden minutes, golden hour, time is life. Second commandment, simulate, teach, and learn and debrief. Develop a simulation culture. What happens in Vegas stays in Vegas. So learn from mistakes and do self-criticism during debriefing sessions. There is no damage done. So which means you learn procedures by simulation, teach the procedures by simulation, and always debrief at the end of each teaching session. So learn all these procedures and multimodal monitoring. For senior fellows, do simulation for younger, new joinees and not depend on national simulation boot camps alone. Third commandment, learn clinical research methodology. Design a study, write up cases, read, learn, and brush up statistics. Get friends with the statistician. Not every fellow, not everyone knows statistics. So it's important for one to learn the basic statistics, to not be afraid of taking up the clinical projects, and also learn to use some softwares like SPSS. These are freely available. Single fascinating article, don't jump on the bandwagon. Don't change the practice. Restrain. No matter how fascinating and tempting it is, you don't just start changing the practice based on one article that has come up. Now, exception. If the ongoing trial had to be stopped because of major event, such as intracranial bleeding in activated protein C in Zygrace, in pediatric septic shock, then that medicine had to be stopped. That trial had to be stopped. Now, more and more studies and literature support Indian data on similar demographics and comparable population. If it shows up in standard textbooks, yes, it's okay. But do you wait for that? If there are articles after articles talking about this, showing a particular treatment to be useful, then one should be able to change the practice, but not at the appearance of just one review article, one case report coming up from somewhere. So look at the national or international guidelines with grades and levels of evidence mentioned. And do take part and take pride in collecting multicentric data. Own country multicentric data is most practical. And there are many of these studies where there is a Western data, but in India, nobody has collected that data. And while being so populated, so many patients, we just have to sort of focus on that. So just as a joke, in one of the lectures, a very famous doctor used to say, if he has seen one case, he goes, in my experience. If he has seen 2 cases, I have seen it over and over again. And if one has seen 3 cases of one particular thing, well, then they say, in my case series. So don't be in a jokey fashion. Do take part and take pride in collecting the multicentric data, collate it properly, do proper analysis, and then publish. Now, 4th commandment, learn to practice multidisciplinary care. PICU is not about ventilation and central line only. It does buy you time while you can think straight about diagnosis, early treatment, and further brainstorming and consultations. Develop skills of PICU care, coordinating with multiple consultants. 2 a.m. to 6 a.m. attention span. You know, this is one thing in the fifth commandment I would repeat by saying, stay awake 2 a.m. to 6 a.m. to down the morbidity and even mortality, because most of the morbidities and errors and mortality occurs during this time slot. Bedside monitoring and central monitoring is the key, and you have to stay bedside, not in your room sleeping. Same thing for the nurses and the intensive care fellows. Sixth commandment, and it's not a minor thing, anger management and stress. You choose it to be in ICU and save lives. Whether patient is okay, better, or worse, never lose temper on the parent or the relatives or the nurses or other team staff. So one has to be very, very calm, quiet, mature, and prevent these outbursts of anger. And as a seventh commandment, there is always a need, as nurses are the pillar of ICUs, nursing liaison, treat them good, teach them, and even learn from them. Remember, you are talked behind your back for good and bad behavior, knowledge, skill level, dealing with the families. A intensivist manner opens the door to bonding with caregivers with honesty, humility, patient advocacy, effectively allowing the staff to be heard. While I'm talking about this, you may see that you have been, working with a very sick patient, and now a new nurse comes in who does not have a good idea about intensive care. Well, don't lose patience. That's where the skills of management of the patient, as well as continuing your ongoing training to the staff, continues. And there's nothing wrong with talking while you're doing things and trying to teach, and trying to also give pause for you to listen to what has been learned or what their concerns are. Eighth commandment, document, document, document. If you didn't document, you didn't do it. Date, time, signature, state council or MCI number or a stamp must be there in all progress notes. Medication name, dose in capital. Pay attention to the decimal error. Now remember, once an event has occurred, and if you did not document, anyone can interpret the chart in any particular way. So therefore, if you have written it in black and white, if you have documented the event, timed it, have put a signature, excuse me, put medication name, dose in capital, you will never go wrong. Number 9, communication skills and calming presence. Be non-committal while being honest in the absence of the senior consultant regarding individual lab reports. Inform the consultant regarding patient trouble or trouble with relatives. A Zen-intensivist manner opens the door to bonding with patients, with caregivers, with honesty, humility, and patient advocacy, effectively allowing the patient and family to be heard. Communication is so very important, including communicating with the family, the nurses, the colleagues, the consultants, and most of all, the relative who has been coming every day, or let's say it's been a close family member who has been involved with the care taking of the patient or getting things done from outside. Sometimes the labs have to be sent outside. So it all boils down to communicating this patient's condition. How was the patient condition upon arrival? What happened through the night? What is the plan for today? How many more days will this patient need to be in the intensive care unit? So communication is extremely important while you have to continue delivery of the intensive care. Last but not the least, 10th commandment, NLT, no loose talk. Volume of laughter needs to be down while conversing about another admission or another matter, especially if there is a dying patient and a grieving family. Be sensitive. Remember, families talk to each other and are always sympathetic. Child only may be sick, but in fact, the whole family is suffering. So in a particular patient who is very sick, all the relatives are very, very concerned and the entire family is sick. So you have to be not only a doctor, but a family counselor, talking to the family in a sensitive, compassionate way, but not doing any loose talk, in front of the family or about a patient while the patient is sick, maybe, but don't do any loose talking. So as academic presentations and seminars are very important, and these days webinars happen, the matter should be studied whenever you make a presentation. Collect the evidence. Each slide should have no more than 5 to 6 points, and use a good font, readable one. Avoid reading paragraph or having to read more lines in sentence with small font. Must have a summary, 2 to 3 slides, key messages, 5 to 6 in a single slide. Use sharp pictures. Black and white written matter is the best. Fancy designs, unnecessary, unless really exceptional that you want to show. So as a fellow, when you enter the ICU, when you enter the armamentarium, when you meet the nurses, start taking care of the patients, it's very, very important that you be communicative, document, pick up research projects, do simulation. So as a concluding point, I would say be learned with calming presence, be holistic as intensivist, first doing no harm, be error-free as much as possible, and have intensivist eye and intensivist speed. Be compassionate with the families with honesty. Acquire procedural and multimodal skills by simulation, as well as by being at the bedside by staying alert. Remember, I talked about 2 a.m. to 5 a.m. And then in the morning, everybody's wondering, I don't know what happened during that time. There is always a reason to it. Look back, look into the situation, be alert, be by the bedside. Now, do participate in clinical research because, yes, in India, we don't have modalities of having the bench research and hardcore research. But I think it's important that since we are such a populated country, we see enormous pathology in the intensive care unit, do participate and collect clinical data and clinical research by being friendly with the statistician, write it up, publish the data, documenting, learning good academics, present good presentations, and finally, be confident to appear for exam. Now, whenever you are taking the exam, it's all going to be practical. It's all going to be what you have done in ICU, what you have learned, maintain your logbook of the procedures, maintain respect for the seniors, and learn by simulation, teach by simulation, and then be confident to appear for the fellowship exam. and wishing you a very, very happy fellowship and a bright Zentensivist status. Thank you very much.
Thank you very much, Dr. Praveen Khilnani. This was really a master class, and I'm sure everybody is motivated. All the fellows are motivated to become Zentensivists now. So I also learned a lot here. And since we have plenty of time, let me see who all we have. So we have Dr. Atul with us. Yeah, he's still there. So I think we will have a few questions and answers from the audience. And Dr. Atul, your talk was very, please unmute yourself. Your talk was very fascinating. So before you, it was Mervyn Singer who presented a lot of data and said that there is a lot of hype and the cytokine is not really a storm, it's just merely a breeze. But he ended his talk by saying that there could be a lot of things happening in the lungs in COVID, but they are not going into the blood. So, and you highlighted a very important point that the youngsters should not jump just because there is a physiological logic to use the drugs. So I want your opinion and message to the youngsters for a lot of anti-cytokine pharmacotherapies, filter therapies in the light of this new knowledge. Dr. Atul.
Tough question, Dr. Pandey, to start with. Well, I'm not. I'm unable to comment specifically on these trials that were quoted by Dr. Singer, but I would say that we should not rush into doing anything, and that has been one of the main mistakes that we made when we adapted hydroxychloroquine, and starting with the ICMR to everyone, they jumped onto the hydroxychloroquine bandwagon. So evidence-based medicine takes time to translate into clinical practice, and patience is most important. You remember we keep discussing in our WhatsApp university or WhatsApp group that there might be biological plausibility, and it makes sense that if the patient has got unregulated cytokine response, then it should produce good outcomes. And the same logic was true for sepsis many years ago, and we had tried using immunomodulators in sepsis and didn't work. I mean, the immunomodulators are not to be seen at all in sepsis. So this is another disease which is not fully understood yet. We don't know how it affects the organ system. So I don't think we should be rushing into giving, all the D-dimer levels and the interleukin-6 levels that we measure. All the cutoffs from what I have read seem to be arbitrary when we are trying to decide the cutoffs by saying that, oh, it's too high and let us try this. And unfortunately, what happens is that we tend to remember when some patient gets better. We forget the fact that we really do not understand why patients get better. They most certainly get better without us, not because of us. So we don't know what works. The patient is getting multimodal therapies, they are getting remdesivir, they are getting lopinavir, they are getting steroids. So the remdesivir trial I quoted, there was a huge group of patients who also received hydrocortisone or dexamethasone, I don't remember which. So it's extremely difficult to attribute the success of a particular therapy unless the groups were completely similar at the beginning of the trial. So my message is just patience, because you remember Zygris, everyone started using Zygris.
Yes.
And now it's not even available. So we should not be in a hurry to adopt these immunomodulator therapies unless we understand the nature of the disease. Sepsis is probably 5,000 years old, and we have still not understood how it exactly happens and how the therapies work. What definitely works in a septic patient is the basic tenets of critical care. You do your housekeeping properly, and most patients will improve. Again, we cannot pinpoint why. We have tried all sorts of innovative therapies in sepsis, and it has been many years since we are at least 30, 40 years since we have tried. So we remember in sepsis, we went from very high dose corticosteroid therapy to now shock dose or a small minuscule dose of hydrocortisone. So these things take time, and evidence-based medicine should certainly be practiced. But the main message is time. Wait and don't be in a hurry. Evaluate the therapy properly and only then use.
Thank you very much. The other thing that you highlighted was that, and it came as a big surprise, that there were more than 100,000 papers that were published. Now, forget about the young fellows, even the senior seasoned people, they would get highly confused. So as a senior person and editor-in-chief of our prestigious journal, what advice do you have for the youngsters if they are scanning the international peer-reviewed journals? How should they, what articles should they, actually put into practice?
So if you think that some article is describing some innovative therapy has surprising results, I would always start with whether this new therapy or the innovative therapy has most important thing is to have is a biological plausibility and a pathophysiological basis. If it doesn't have that, then it might be just random chance that it is working. Remember this, there is this fashion nowadays of doing proof of concept studies, which essentially means that you take a convenient sample size of a very small number of patients and say that this is the proof of the concept that I am putting forward. So single randomized control trial is not enough. The classic example is the Vandenberg trial. It was a large trial. It was not a small trial. It was a large trial. So everybody, if we had, fortunately, we couldn't jump onto that bandwagon in India, most of us, because it is so resource and staff incentive that we could not afford to do intensive insulin therapy. Okay, and next 10 years, we have come down again back to keeping the blood sugar within reasonable limits instead of a very tight control, because in medically critically ill patients, it actually can kill patients. So the same thing is true for any new concept. So I am sure that every new entrant should read these papers, make sure that the paper is in a reasonably good journal. If possible, it should be from a good working group or well-known authors who have a good pedigree. The mistakes that Lancet and the NEJM made were probably because of the rat race to publish and publish fast. And that doesn't happen very, very frequently. I mean, the retraction rate is very, very high, like I said earlier in my talk. And maybe occasional slip-ups do occur. And when the editors of these journals were interviewed, they said that there was immense pharma pressure to publish this trial. I'm sure you are familiar with this, but that's very rare. So you look at the journals like intensive care medicine, for example, or critical care medicine. They have a very, very thorough vetting process. They have a excellent and robust review process. So if you follow these journals, and again, wait for confirmation from another group, if possible, because you remember the recent story of vitamin C, everybody jumping on vitamin C bandwagon. And the first trial was just a before and after study. So you look at the trial design, whether it's blinded or not blinded, so on and so forth. The new trial design that is coming in, now I'm sure in next 5 years, we'll see a lot of trials, which will be like the remap CAP studies, like adaptive trial designs. But remember again that there can be fallacies if people try to adapt that design. So sure, the trial design allows you some flexibility, but the thing that we should not forget in this trial design is that the flexibility is only for pre-planned changes in the trial while you are recruiting more patients. You cannot make post hoc changes which are not planned before into the trial design. So there are some pitfalls in every design, and we should watch for those pitfalls.
Thank you. I can see Dr. Ram Rajgopalan and Dr. Dhruv Chaudhary are there in the audience. So if you guys would like to make any comment, Dr. Ram and Dhruv.
I saw Dr. Diveti also, I think.
Yeah, Bharat, would you like to add something, some comments?
But no, sir, what really sir said is absolutely, I'll just put into the crux of it. As he said, we have to look into the details of the designing of the study, and we should not be jumping into just to, if the physiology of the drug matches with the disease process, we should not be matching into it. One interesting question has been put up by the Devatia sir. I think he's left. What he's thinking, if it was actually towards the Marvin, and what he said is, if IL-6 inhibition, as in recovery and remap cap, has shown it improves the outcome. So do we have to reevaluate the role of IL-6 inhibitors in the standard bacterial sepsis? So it's a double-edged sword if you because I don't think viral and bacterial sepsis acts in the same way. Those are totally different. Now we might come up with a terminology saying viral sepsis and the bacterial sepsis. So those both need to be handled in a different way. But what COVID has helped us is understanding the viral sepsis in a better way. So now I think we'll be in a better position to deal with the other viral disease as well. This is what it is, sir.
Yeah, but if you see
Dr. Pandey.
please.
Yes,
Yeah.
sir.
No, I just had a comment on what Bharat just said. And there are now questions being raised in the literature in the last couple of months, whether sepsis, we say that it is viral sepsis and the COVID-19 has made our understanding of viral sepsis better. But there were questions being raised now whether it is actually viral sepsis at all or it's a localized disease. So our understanding of the disease is extremely incomplete as far as COVID-19 goes. And I think we should be very, very careful in applying the lessons of this again to bacterial sepsis. Remember, there are so many things that we do not know how they actually happen in sepsis. The pathophysiology. So this is extremely true for cancer patients. You know, I mean, I work in a cancer hospital, though I don't read their literature. But when you hear about the tyrosine kinase inhibitors and angiogenesis receptor blockers, etc., in cancer therapy, the God's design is so great, or God or whoever you believe in. The design is so great that there are multiple pathways which amplify the response to, say, an organism or to cancer or a bacteria or a virus. You block one pathway and the nature takes another path to create the same effect.
Absolutely.
And that is the reason why these blockers, don't seem to work. And that's what happened to Zygris precisely. We said that we are blocking one particular pathway of coagulation and this will solve the whole problem. It didn't work. Probably because the same thing is happening in all these therapies. We think we have found an innovative way of getting at the disease, and God works in mysterious ways.
I understand. You know, one thing that has foxed me is remdesivir study showed that it is beneficial in lesser sick patients. Dexamethasone showed benefit in more sick patients. So we don't know how to interpret these studies. So maybe time will only guide us. Dr. Dhruv Chaudhary.
Rajesh, it's an interesting discussion actually. Good morning, Atul and
Good
Bharat.
morning.
You see, it's an interesting discussion, but I always say one thing as a clinician, and I'm a hardcore bedside clinician, not sitting in this thing. What my understanding as a student of medicine has been, stick to the basics, understand the pathophysiology, and then try to modify your treatment depending upon that. Look at the saga of tocilizumab. We have participated in that trial. Now it has been accepted for publication in Lancet Respiratory, which was initiated by Dr. Soin from Medanta. What we are looking at it, that when you see the trials have their own limitations because you have a lot of exclusion and inclusion criteria and you took a very selective population. But when you come to the clinical side, that helps you in taking a call. And what we have realized is that those who have an acute deterioration, if they are not responding in corticoids, there is a very small subset of these cases where we have been using tocilizumab. And Atul is very right. Nature has multiple pathways. You try to block one, the other pathway becomes the dominant pathway. That is why steroids or now JAK1, JAK2 are becoming more and more prominent because they are at the upper end of it from where the downregulation starts, responsive to it. And it reminds me a very common simile which we have been seeing, Atul, in Maharashtra, I mean, particularly in Mumbai, is that of leptospirosis. In the second week, when they are having a significant diffuse alveolar hemorrhage, we know that this is basically secondary to immune mechanism. So I think that's becomes an important part for us to understand. So we have to follow the pathophysiology. And that is where the William Osler words becomes very important a century down the line now, that whenever you have an infection, either the host will survive or the pathogen will survive. And that ultimately will depend upon the response of the host immune responses today, which we are very elegantly talking in terms of sepsis being whatever may be the cause, immune dysregulation. Therefore, I think the answer to large number of these lies in our genes, how they look at it, how they react it, and whether they are able to retrieve back the things in time or not. Now, this is a very broader philosophical view, but I think we probably may have to act at an up level. IL-6 has shown us efficacy from the CAR T cell therapy. Yes, that is what is happening. And clinically, now you see the switching over from the dominant lymphocytes or neutropenia to leukocytosis and neutrophilia is telling you the change over time where we are heading for a trouble. So I think it has given us a lots and lots of insight. And I have no doubt in my mind that in patients of COVID, we need to use both antiviral to reduce antigenemic load. And at the same time, you need immune modulators to modulate the dose. And trust me, now we are following these patients in our clinics and post-COVID clinics. And what we are realizing, a large number of people using antifibrotics. That's again a phase which is coming up. But we are using corticoid because they have organizing pneumonia-like pictures and the radiology. And out of, let's say, if I'm using 10 cases, I have not required more than in 10, 15% of the cases to use antifibrotics. So by and large, it suggests us it's an immune phenomenon. The data again shows it is not persisting. So whatever you are being ravaged at that point of time, and I completely agree with Atul.
Bharat, I hand it over to you because we have 3 minutes left. So, Dr. Atul, if you have any last minute comment, otherwise we'll close this plenary session.
No, I would just want to reinforce, and you said this before, and all the senior ones keep telling us, one is don't forget the basic critical care. I mean, you can use the latest trial designs, you can use the latest drugs and latest. If your housekeeping, the basic critical care is not great, the patient is unlikely to make it. That is the most important message.
Absolutely. Devatia sir has raised a hand. I think he would like to
Yeah, please, Dr. Devatia.
Yeah, good morning. Thanks,
Good morning.
Bharat. Dr. Pandey. I'm not suited and booted, so I'm not switching my video on.
Doesn't matter.
All I'd like to say, the problem with the pandemic, and Atul made that very nice point about waiting for evidence and being patient. But I guess at the beginning there was more panic and confusion than anything at all, and people were dying and people wanted something to do something for our patients. At the end of the day, I think in retrospect, we've realized that basic intensive care has saved more lives than any drug or any intervention that has done. But in the beginning of the pandemic, there is no data, there is no evidence, and people were relying just on biological plausibility and physiologic and pharmacologic to do things. I think the key is that when you do these things, you should document everything very meticulously so that you can always review your experience and in a more scientific fashion at the end, rather than loosely make statements that I use this and this works and that is fantastic and that doesn't work. So I think in future, I'm sure there will be more pandemics in coming up, or more sort of disasters coming up. And we must use this experience to document our future strategy, that of at least documenting what we do, so that we can evaluate all our decisions and our interventions critically.
Absolutely.
And I think
yeah.
Immune saga is not over. In sepsis, we still haven't understood whether it's hyperinflammatory, hypoinflammatory, when one switches from one to the other. And the same thing, I think COVID has taught us that in a very short time, what we've struggled for in 30 years with sepsis.
So we
Thank
are
you.
running
Thank you
out
very
of time,
much.
but I would like one comment from Dr. Devatia, sir. Why do you say we are going to see more pandemics in future, sir? What makes you say that?
Well,
Possibly
it's a
endemic.
given.
we narrowly escaped SARS, we narrowly escaped MERS. We were hit partially by H1N1, and now we've been taken full on by COVID-19. So we were
it's a given. It's a given that pandemics are coming.
lucky the
It's a given.
Pandemic definitely are coming, and what we look at it from the public health perspective, if you really look at it, it's the respiratory ones which are the one, because they are the one which spreads like it. We were fortunate, as Dr. Devatia said, that we were lucky to get away from the MERS as well as SARS-CoV. And I just want to share it. You will be surprised that Government of India had actually made a full task force for MERS-CoV when it started coming up, and I happened to attend that one. That was around about 4 years or 5 years ago. So probably now we have to be in a ready preparation, and I think it also makes it important for all the institutions, in particular the teaching as well as the corporate, to have a state-of-art microbiology labs or virology labs where we pick it, and majority will come from zoonotics and majority will be the viruses.
Thank you very much. We close the session here, and back to the tech team. Thank you. Please take over.
Yeah.
Thank you. Thank you all.
Thanks a lot. Thanks, Dr. Rajesh, for conducting this session. Now we move to the next session, and we have the chairperson, Dr. Vishal. Dr. Vishal, you around?
Yeah.
Yeah, Dr. Vishal. Yeah. Welcome. I am Dr. Bharat Jagasi. Welcome you, and please now this is yours. You can just take over the next session. You can introduce the next speaker, please. Thank you. Over to you, Dr. Vishal.
Hello. Now, thank you, ISCCM and the organizing committee for inviting me to chair this important session of the near antibiotics. We are sitting at the current era of a lot of antibiotic resistance, and I think everybody is facing that menace. Now, today's thematic session is about the newer antibiotics. Look into how we can see how these newer antibiotics can help us. And the first speaker is Dr. Ritesh Shah, who is Director Critical Care Unit at Sterling Hospital, Baroda. His topic will be on levonadifloxacin. So over to Dr. Ritesh Shah.
Hello friends, I am Dr. Ritesh Shah from Vadodara, Gujarat. I am going to talk to you about newer antimicrobial, that is levonadifloxacin. Now it is benzoquinol is in subclass of fluoroquinolone, and it is available in IV as well as oral use. This is a chemical structure that I am not going to go much of detail, but these are unique characteristics, like this ring imparts potent activity against MRSA as well as VRSA. And there is substitution of 4-hydroxypiperidine side chain, which makes it having better permeation and enhanced target affinity. And this OH group significantly enhances its activity in acidic medium. As far as oral drug is concerned, it is a prodrug, but having 85 to 90% bioavailability with good GI tolerance. Why it is required? Because as compared to other anti-MRSA, if we talk about other anti-MRSA antibiotics, there are certain drugs which are bacteriostatic or variable bactericidal activity. Some drug is associated with some MIC creep, variable tissue penetration, and organ toxicity. So we need to adjust their dosage in organ failures. It is not suitable for longer therapy as well. And there are some drug which is having black box warning from US FDA for all cause mortality. That is why we need some robust anti-MRSA drug. There is a special status given by US FDA, that is qualified infectious disease product to this drug.
What is the mechanism of action? It does have good mechanism of action against DNA gyrase as well as topoisomer 4 isomerase 4 mutations. So because of these two actions, it does have significant potent activity against MRSA. On the top of that, there is no impact on efflux pump, which may be having a kind of contribution in development of mechanism of resistance. See, we know that biofilm formation is a major challenge in infections like, device-associated infection, line-related infections in ICU, diabetic foot infections, bone and bone joint infections. So biofilm is really a big concern as far as ICU patient population is also concerned. So this is one of the study which has suggested that excellent penetration of leonardifloxacin, and it is associated with biofilm eradication, which is one of the most important and unique property. It is absorbed, the oral form is absorbed with the help of amino acid transporter in the intestine, short Tmax, high Cmax, 90% bioavailable, and there is no food drug interaction as far as this drug is concerned. It is metabolized through hepatic phase 2 conjugative metabolism, and the sulfate is its predominant metabolite, and because of its lack of inhibition or induction of C450 cytochrome P450, it does have minimum drug-drug interaction. Serum protein binding is almost 70 to 90%, so it is favorable tissue. It does have favorable tissue and unbound plasma concentration. It is excreted through both urine and feces, but the unchanged drug is excreted through renal pathway, which is very less, that is less than 3%, and that is why the pharmacokinetics are not expected to be affected in patients who are having renal issues. See, these are matching pharmacokinetics between oral as well as IV formulation. Why it is important? Because the switchover, we can do switchover from IV to oral with reasonable confidence. There is a huge intrapulmonary concentration. Like see this, high epithelial lining concentration, high epithelial lining fluid concentration, which is 7 times more than the plasma, and alveolar macrophage concentration, which is twice as high as compared to plasma. So because of this intrapulmonary PK profile, that makes this drug suitable for the treatment of lower respiratory tract infections. In hepatic impairment, though it is metabolized through liver, but the dose adjustment, because of its unique metabolism characteristics, no dose adjustments is required in patients having hepatic issues. See this spectrum, gram positive like Staph aureus, MSSA, MRSA, quinolone resistant Staph aureus, vancomycin resistant Staph aureus, Staph epidermidis, Streptococcus species including pneumonia viridans group, gram negative like E. coli, Klebsiella, Pseudomonas, Moraxella, H. influenzae, Enterobacter, certain Enterobacter species, Cytobacter species, Proteus and Providentia. Having good anaerobic coverage as well is including C. difficile, Clostridium perfringens, Peptostreptococcus, etc. And good atypical bacteria coverage, that is Mycoplasma, Chlamydia, Legionella, Ureaplasma, etc. So all gram positive, negative, anaerobe as well as atypical bacterial coverage is there, which also makes this drug as unique. It is having very high density killing property of MRSA and QRSA. See this bacterial log control as compared to other anti-MRSA drug. Over a period of time and high concentration, the bacterial log does not decrease much as compared to leonardifloxacin. It does have enhanced activity under acidic medium, so that it does have favorable feature for effectiveness in community acquired MRSA infection associated abscesses as well as intracellular infection, acute bacterial skin and structure infection, or hospital acquired pneumonia. It is indicated in these are the labeled indication like acute bacterial skin and skin structure infection, including diabetic foot infections and concurrent bacteremia. The dose is it's available in 800 milligrams, so every 12 hourly to be infused over 90 minutes, and 500 milligram tablet is available, and 2 tablets, that is 1000 milligram every 12 hourly with or without food. There are some contraindications or caution that I'm going to talk to you about. Because it does have minimum cytochrome P450 mediated metabolism, so drug-drug interaction is unlikely or less. But we need to remember that it should not be co-administered with multivalent cations like magnesium through the same IV line.
In special population, like there is no dose adjustment it is required in hepatic and renal failure. In geriatric patients, anyway, caution we always exercise in choosing this any kind of drug, especially when those on corticosteroids. It is not studied or recommended in patients having less than of 18 years. Pregnancy safety has not been evaluated, so as far as today is concerned, we should avoid using this drug to be utilized in pregnant patients. It is available in single ready-to-use glass bottle to be infused over 90 minutes and no data available for compatibility. So we must remember that there should not be any drug concomitantly administered when this drug is going on over 90 minutes. The side effects, adverse events as compared to linezolid, like constipation is one of the major. Otherwise, vomiting, nausea, pyrexia, chills, hyperglycemia, low HB, these all are either comparable or less to linezolid. In some patient population, we need to have caution to use this drug, like tendinitis, tendon rupture. It does possess, other fluoroquinolone associated CNS effects like anxiety, nightmares, convulsions, disorientation, confusion. In peripheral neuropathy patients also we need to avoid as far as possible use of this drug. It can cause exacerbation of myasthenia gravis, and photosensitivity, phototoxicity to ultraviolet and visible radiation is also there. It can also cause dysglycemia. So in certain patient population, as far as possible, we should not use this drug, or if we at all we want to use, we should use with caution. No drug is out of resistance, but so resistance can arise through mutations in defined regions of either DNA gyrase or topoisomerase 4 called quinolone resistance determining regions, or popularly known as QRDRs. Through altered efflux, as I already said, that there is minimum effect on efflux pump. But if that efflux pump does have altered pathway, then this drug also can get resistance. And as with all the drugs, cross resistance may occur with other fluoroquinolones, but overall it demonstrates superior resistance suppression feature. So this unique feature probably will allow us to use this drug for a longer period of time. So it's very safe as compared to other anti-MRSA drugs. Good GI tolerance, no hepatotoxicity, no QT interval prolongation, no phototoxicity, and no dose adjustments is required in even renal failure patients. So this is one of the study which suggests that there is no correlation or no effect of this drug as far as QT prolongation is concerned. So we can utilize this drug in acute bacterial skin and skin structure infection, diabetic foot infections, community-acquired pneumonia, bone and joint infections, febrile neutropenia on bone marrow transplant patients, or device-associated infection whenever we think that patient is probably having MRSA or grade gram positive, some gram negative, but simultaneously if biofilm formation is also there, then this becomes a drug of choice. There are a variety of studies which were done for dose as well as effect in phase 1 and phase 3. I won't go into much of the detail. Majority of the studies are done in India as well as in US. One of the studies suggested very high clinical and microbiological cure rates with this drug when compared with MRSA patients and use of linezolid in MRSA patients. This is a chart which is compared with other fluoroquinolones. So as compared to other fluoroquinolones, it does have very good anti-staph aureus or anti-MRSA activities, including quinolone resistant staph aureus. It does have very strong action against MRSA or QRSA biofilms. There is enhancement in activity in acidic medium, highest lung penetration among other fluoroquinolones, and it's liver safe, renal safe. So as compared to other fluoroquinolones, it does have slightly higher edge to be utilized. If we compare it to other anti-MRSA drug, it is more potent, excellent lung concentration. It does cover anaerobes also, good GI tolerance, very good action against MRSA biofilm, excellent tolerance, GI tolerance already said, and renal as well as liver safe. So as compared to other anti-MRSA drug, this does again is having kind of slightly higher edge. One of the study which was done, it was compared with linezolid for acute bacterial skin and skin structure infection. It was phase 3 open label randomized study, and it does suggest that it is non-inferior to IV or oral linezolid. There is some comparison, vague comparison with teicoplanin. Yes, I must say these are just theoretical points, but yes, we do have the kind of comparison of property. Like teicoplanin is having slow bactericidal activity. It does have some MIC creep. 2 to 3 days are required to reach the therapeutic levels because it requires loading dose. This drug doesn't require loading dose. Better atypical and anaerobe coverage where teicoplanin does not have. It may be having some renal toxicity where this is not having, and lung concentrations are suboptimal, whereas levonatifloxacin is having excellent lung concentration. In teicoplanin, no oral formulation available, where levonatifloxacin IV to oral use switchover is relatively easy. So if I want to summarize, this drug, levonatifloxacin, and its oral form have a potent activity against gram-positives such as Staph aureus, including MRSA, quinolone-resistant Staph aureus, vancomycin intermediate resistant Staph aureus, or vancomycin-resistant Staph aureus, plus MDR streptococci. The monotherapy is potential to broad spectrum coverage of gram-positives, negatives, anaerobes, including C. difficile and atypical. So a pretty wide coverage as far as spectrum is concerned. It does have strong bactericidal action and intracellular killing ability. Most important, it is effective against biofilm because of its unique property which allows it to permeate or penetrate into biofilms, which is one of the most important thing as far as ICU patient population is concerned. There is enhanced activity in acidic conditions, so no renal or hepatic dose adjustment required. Favorable tissue distribution, that is high plasma as well as lung concentration. Availability in IV plus oral options. So most important, without any kind of bioavailability issues. So if you want to switch over once gut is ready, once patient is slightly better, we can easily switch over from IV to oral with reasonable confidence that this drug is having the same, going to have the same effect as IV. And no effect on oral exposures. So no food drug interaction as well as no drug drug interaction because of its no or minimal activity against cytochrome P450 inducers. Excellent GI tolerability, freedom from biochemical, hematological, and CV safety parameters. So GI safe, renal safe, liver safe, as well as CVS safe as far as QT prolongation is concerned. So let's hope that this drug helps us in our multiple patient population, especially in biofilm formation, in patients having biofilm which are very rigid to get rid of. So thanks a lot for patient listening.
Thank you, Dr. Ritesh Shah, for your lecture. Now, moving on, the next lecture is on isovolaconazole, and the next lecture is on isovolaconazole. And for this lecture, I invite Dr. Anand Nikalje, who is the Director, ICU Associate Professor at MGN Medical College, Aurangabad. Over to you, Dr. Anand Nikalje.
Dear friends, welcome to Criticare 2021. I think this virtual conference is new normal for all of us. And when pandemic is not over, I can understand how much efforts and pain probably these organizers have to take to make this conference for all of us. Thanks, organizers. I'm going to speak today on a new and a novel antifungal agent, that is isavuconazole. Friends, in last decade, the incidence of invasive fungal infections are on rise because of steadily increasing number of immunocompromised patients as well as ICU patients. Invasive fungal infections are major cause of morbidity and mortality in critically ill patients. Almost 20% of microbiologically documented infections in intensive care units are contributed to fungal infections. The most common pathogens associated with invasive fungal infections in humans are Candida, Aspergillus, and Mucormycosis, out of which 80% are Candida species, which is the third most common isolate found in intensive care unit. There are a lot of antifungal agents been proposed and discovered in last 10 to 20 years. Routinely, for invasive fungal infection in non-neutropenic ICU patient, we use three common category of drugs. One is polyenes, which is amphotericin B and nystatin. A big group is azoles, contains fluconazole, itraconazole, voriconazole, posaconazole, and isavuconazole. And third is echinocandins, which contains caspo, mica, and anidolafungin. There are a lot of issues when we actually choose antifungal agents. Few have got limited spectrum of activity, resistance is high. Some antifungal agents have no oral formulations. They have got significant adverse events profile. Then multiple drug-and-drug interactions with these antifungal agents that we have to consider as a problem. And most of them have variable pharmacokinetic profile. So when we choose or wanted to choose an antifungal regimen for our ICU patient, we have to consider multiple factors like epidemiological data, patient's characteristic, hospital setting, fungal strain, site of infection, and safety profile of this antifungal agent. Most of them act on a fungal cell wall. The azole in which we are interested today, they act on the endoplasmic reticulum and inhibit the synthesis of estradiol, which is very important part of the cell membrane. Azole is a big agent, antifungal agent, and it is a great therapeutic option for systemic fungal infections. There are two types of azoles, triazoles and imidazoles. The isavuconazole is a triazole compound. Isavuconazole is approved by US FDA in March 2015. It is formulated as a prodrug. It's called as isavuconazonium sulfate, and it is available as IV as well as oral formulation. Isavuconazole has prolonged half-life, that is 130 hours, which enables once daily dosing when we give 2 days of loading dose 8-hourly, that is 6 loading doses followed by once daily dose. Another important thing is that it has got large volume of distribution, 450 liters, which suggests that it has got high tissue penetration. Isavuconazole is available as an oral capsule and is well absorbed. Interestingly, it has got 98% bioavailability when it is given orally, and it doesn't get altered with food intake. When we open the capsule and give internal feeding via tube feeding, where most of our ICU patient needs, the results are similar to intravenous administration of this drug. It is cleared highly dependent on hepatic cytochrome P3A4 metabolism, and thereby this drug has got multiple drug interactions which we are going to learn. The approved indications are invasive aspergillosis and mucormycosis, invasive mucormycosis, where amphotericin B is not appropriate for this patient. The approval of isavuconazole is based on two main clinical trials. One is secure trial, another vital trial. The secure trial assessed the efficacy and safety of isavuconazole versus voriconazole in patient with invasive mold disease. Patient with suspected invasive mold disease were randomized in 1:1 ratio using interactive voice web response system, stratified by geographical regions, allogenic hematopoietic stem cell transplantation, and active malignant disease at the baseline. The patient randomized to isavuconazole, almost 258 patients were started on IV formulation, 200 milligram 3 times a day, and then continued or switched over to capsule after third day. The patients assigned voriconazole, almost same number of patients, were given drug intravenously for day 1 and 2 with 6 milligram per kg twice daily, then 4 milligram per kg twice daily, and then continued either oral voriconazole or IV voriconazole 200 mg twice daily from day 3. After median of 45 and 47 days of treatment, all-cause mortality found in both the group were similar, 19% and 20%. The corresponding treatment response rate with proven or probable invasive aspergillosis were almost same, like 35 and 36%. The secure trial also found the elevated liver enzymes in these patients, 17% in a group of isavuconazole versus 24 in voriconazole group. When they studied drug-related adverse events, they found that almost 42% who received isavuconazole had side effects as compared to more number of patients, that is 60% of the patient in voriconazole group. The difference is statistically significant. The secure trials conclude that the isavuconazole was not inferior or almost comparable to voriconazole for the primary treatment of suspected invasive mold disease. Isavuconazole was well tolerated as compared with voriconazole, with fewer study drug-related adverse events. Our results support the use of isavuconazole for the primary treatment with invasive mold disease. So, the secure trial clearly shows that this drug can be used for invasive aspergillosis as an option. Then another landmark study is the VITAL study, which is a single-arm open-label study which included adult patients more than 18 with invasive fungal disease caused by rare fungi including mucormycosis. They were recruited from 34 centers worldwide. The patients were given isavuconazole 200 mg 3 times daily for 6 doses, followed by 200 mg per day until the fungal infection is resolved or failed, or for 180 days or more. The mucormycosis cases treated with isavuconazole as a primary treatment were matched with the control from the Fungiscope registry recruited from 17 centers worldwide who received amphotericin as a primary treatment. And they were analyzed at day 42 for all-cause mortality. Within a VITAL study, almost from 2008 to 2013, 37 patients with mucor received isavuconazole for almost 84 days. By 42 days, 4 patients had partial response, 16 had invasive stable infection, 3 had fungal disease progression, 3 missing assessment, and 13 patients have died. 35%, that is 95%, had adverse events. Day 42 crude all-cause mortality is 33% in primary treatment of isavuconazole, which was almost similar, that is 39% of amphotericin as a primary treatment in a matched control group. So interpretation of this VITAL study is that isavuconazole showed activity against mucormycosis within the similar efficacy of amphotericin B. Isavuconazole can be used for treatment of mucormycosis, which is well tolerated. The safety cohort of 433 patients was done, and the side effects were analyzed. The most common side effects were nausea, vomitings, dyspnea, abdominal pain, diarrhea, injection site reactions, headache, and rash. Skin, eye, and hepatobiliary disorders were less common with isavuconazole than with voriconazole. Few adverse effects like shortening of QT interval, so it is not recommended in patients with familial short QT syndrome. It is category D for pregnancy, so it is not recommended for pregnancy. It is also not recommended during lactation, as there was evidence of excretion in the milk of lactating rats. Isavuconazole has got many potential drug interactions. It should not be given concomitant with ketoconazole, high dose of ritonavir, drugs that strongly induce cytochrome P450 like rifampicin, carbamazepine, phenobarbital, or phenytoin. It is also contraindicated with moderate cytochrome 3A, 4 or 5 inducers like efavirenz, nafcillin, and itravirin. The product information recommends that no dose adjustment is required for oral for this renal and hepatic impairment patients. Drug has not been studied in severe hepatic impairment, but in mild to moderate, it is definitely recommended. The role of isavuconazole in the invasive fungal infection has been studied in this trial in 2016. The phase 3 studies have evaluated efficacy of this drug in management of invasive aspergillosis, mucormycosis, and even in invasive candidiasis. Based on the result of these studies, isavuconazole appears to be a viable treatment option for patients with invasive aspergillosis as well as those patients with mucormycosis who are not able to tolerate or fail amphotericin B or posaconazole. But in contrast, evidence to isavuconazole for invasive candidiasis is not robust. So, isavuconazole use for invasive candidiasis may be initially reserved as a step-down oral option in those patients who cannot receive either azoles or due to tolerability or spectrum of the activity is limited. Whether we can give this drug to patient with renal failure. The increased water solubility of the isavuconazole prodrug, that is isavuconazonium sulfate, facilitates formation of the solution without adding cyclodextrin. This cyclodextrin actually limits the use of voriconazole and posaconazole because it causes renal toxicity in patients with creatinine clearance less than 50. Due to lack of cyclodextrin and minimal renal excretion, isavuconazole can be given to the patient with mild, moderate, and severe renal impairment patient without need of dose adjustment. Patients with mild to moderate hepatic impairment exhibit a decrease in the clearance of this drug, but such reduction do not warrant dose reduction in this patient. Currently, there has been no data which supports use of this drug in severe hepatic impairment patients. Safety and tolerability in general, isavuconazole is a well tolerated, appear to be have similar safety profile than fluconazole. Phase 2 and phase 1 studies shows no serious adverse effect to this isavuconazole drug. Phase 3 clinical trials actually appear to have more favorable safety profile compared to voriconazole and comparable safety to caspofungin. The drug has been studied for invasive CNS fungal infections. This study published in International Society of Human and Animal Mycology in 2020. The aim of study was to assess the effectiveness of isavuconazole in the treatment of CNS invasive fungal disease. Data were collected from, again, vital and secure trials. Isavuconazole was administered as a primary therapy to 20 patients and a salvage therapy to 16 patients. The median duration of isavuconazole therapy was 103 days. Patients were switched to isavuconazole oral therapy after median duration of 30.5 days of injectable therapy. In this invasive fungal disease, 11 patients had got mucor. Then 8 patients have got aspergillus as the most common invasive central nervous system infection. Few patients has got cryptococcus. Some have got dimorphic fungi. So, variety of fungal infection were present. The analysis provides the effectiveness of isavuconazole as a treatment of invasive fungal disease with CNS involvement. The overall survival rate was 80% at 42 days and almost 70% at the end of 84 days. In the present retrospective study, treatment of isavuconazole was effective against serious infection caused by a wide range of different fungi. This data also support previous animal studies that showed that effectively the penetration of isavuconazole is good across the blood-brain barrier. The other recent study reported high concentration of isavuconazole in inflammatory brain tissue as compared to healthy brain tissue in 2 patients with Aspergillus fumigatus infection. So this report suggests that isavuconazole may be a valuable option in the treatment of invasive fungal disease. So isavuconazole is a new triazole agent that can be given once a day offer a wide range of antifungal activity than voriconazole, which includes mucormycosis. It has got excellent bioavailability and predictable pharmacokinetics. It can be used in a patient with renal failure without dose modification, and it is presently approved for treatment of invasive aspergillosis and mucormycosis. Thank you and take care.
Thank you, Dr. Anand, for providing insight into the new antifungal isobuconazole. Now, moving on to our next lecture. Next lecture will be on ceftazidime avibactam, and the speaker is Dr. Kapil Barake, who is a consultant critical care at Prague Hospital, Pune. So, over to Dr. Kapil.
Good afternoon, all. I'll be talking about newer antimicrobials, ceftazidime and avibactam. The mortality burden of MDR gram-negative infections, particularly critically in patients with prior antimicrobial exposure or comorbidities, are particularly vulnerable to infections with MDROs, which can increase mortality, hospital cost, and length of the hospital stays. The infections with MDR and extensively drug-resistant E. coli, XDR Klebsiella pneumoniae, MDR Acinetobacter were associated with 2 to 3 times higher mortality. So what are the strategies to overcome this resistance? Current options for treating MDR gram-negative pathogens is aminoglycoside. There is a rising resistance among CREs. Toxicity associated with these drugs and is used in pneumonia is question mark. The colistin is a last resort used despite toxicity. Nephrotoxicity and neurotoxicity is concerned. The optimizing dose is a challenge. Promotion of resistance is there due to use of suboptimal dosages, and it has a narrow therapeutic window. Tigecycline has no activity against Pseudomonas, and it has limited to CRAIs. Now, fosfomycin approved by FDA in the treatment of uncomplicated urinary tract infections, but associated with hypokalemia and hypernatremia. No RCTs are available on clinical efficacy and safety as compared with the other antimicrobials. With increasing use of colistin for the treatment of carbapenem-resistant gram-negative bacterial infections, colistin resistance among gram-negative bacteria has emerged in India. The bloodstream infections due to dual carbapenem and colistin-resistant Klebsiella pneumoniae are associated with 69.3% of mortality among Indian patients. Now, so what is the strategy to overcome this? The beta-lactam are one of the most commonly used antimicrobial agents in the management of infectious diseases. Enzymatic inactivation of beta-lactam by beta-lactamases has emerged as a significant clinical threat as they are diverse and can rapidly disseminate. To circumvent the emergence of the resistance, novel and broad-spectrum beta-lactam inhibitors, that is BLIs, are being developed in combination with beta-lactam to restore their activity. So novel BL-BLI combination, what are the options? Ceftazolazone with tazobactam, ceftazidime avibactam, meropenem varobactam, and imipenem cilistatin with relibactam. So here we'll be talking about ceftazidime avibactam. Now, ceftazidime is a third generation cephalosporin. Avibactam non-beta-lactam, beta-lactamase inhibitor. It's first in class. Inhibition of beta-lactamases is covalent but reversible, the characteristics that other known beta-lactam inhibitors lack. The activity of avibactam is reinstated once acted. The spectrum of activity, in vitro activity against many important gram-negative pathogens, many ESBLs, MCKPC, OXA48 producing Enterobacteriaceae, drug-resistant Pseudomonas isolates, least effective against Acinetobacter and metallo-beta-lactamases. Understanding OXA48 is very important. 11 enzyme variants have been identified across the world. Mortality remains very high in patients infected with OXA48-like producers. OXA48 frequently reported from E. coli and Klebsiella pneumoniae, and high level of OXA48 resistance is associated with co-production of extended spectrum beta-lactamases. Now, co-production of OXA48 is also seen with other carbapenes producing, including NMDA and VIM. So what is the effective drug treatment for treating infections due to OXA48 CPEs? The importance is ceftazidime avibactam. When they have seen the effectiveness of this drug in the treatment of infections to OXA48 carbapenes producing Enterobacteriaceae, the study was done in Spain. 57 patients with OXA48 positive Enterobacteriaceae. Isolates were OXA48 producing Klebsiella pneumoniae in 54 cases, E. coli in 2 cases, and Enterobacter cloacae in 1 case. Source of infection intra-abdominal in 28%, pulmonary in 26%, and urinary in 25%. The primary outcome was 14-day all-cause mortality. Most, that is 81%, received ceftazidime avibactam as a monotherapy. Clinical and microbiological cure were achieved in 77% and 65% patients respectively. All-cause mortality rates assessed at 14 to 30 days were 40% and 22% respectively. Development of resistance to ceftazidime avibactam was not detected in any patient during the whole follow-up period, which is very important. Now, only 2 patients developed adverse events related to the treatment. The clinical characteristics and prognosis of infections caused by Klebsiella carbapenes producing Enterobacteriaceae in patients treated with ceftazidime avibactam. It is again a retrospective analysis of 24 cases of OXA48 CPE. Intra-abdominal infections, urinary infections, and respiratory infections were the most common sources. Ceftazidime avibactam was administered as monotherapy in 14 patients, that is 58.3%. 30-day and 90-day mortality rates were 8.3% and 28%, 20.8% respectively. The clinical cure at 30 days was achieved in around 62.5% of the episodes, while only 4 patients had adverse events. The efficacy of ceftazidime avibactam in the treatment of infections due to carbapenem-resistant Enterobacteriaceae, the study was done in Saudi Arabia, where 38 consecutive patients with CRE infections were included. The most common type of CRE infections in both groups was hospital-acquired pneumonia. Klebsiella pneumonia was most common organism, and ceftazidime avibactam has compared with other agents. A carbapenem gene was detected in 35 patients. The OXA48 gene was the predominant gene identified in 74% isolates. 8 out of 10 patients in ceftazidime avibactam group and 15 out of 28 patients in the comparative group achieved clinical remission. After 30 days, all-cause mortality was observed in 5 patients in ceftazidime avibactam group and 16 patients in comparative group, accounting 50 to 57% respectively. When we are talking about CRE, ceftazidime avibactam as a preferred empirical choice when both KPCs and OXA carbapenes are reported locally, or we can use meropenem varobactam. What are the key questions is how the clinician should be driven in his or her therapeutic decision. What is the importance of local epidemiology? Will monotherapy be sufficient option? Could it be predicted how long the beta-lactamase inhibitor combination will survive? And the importance of stewardship. The early use was associated with improved outcome. The study by Temkin et al., 79% of patients with negative cultures at the end of the treatment survived until discharge. They suggest that the waiting to exhaust all other potentially more toxic treatment options before resorting to ceftazidime avibactam may reduce patients' likelihood of being cured. Similar study by Jagerson et al., they showed that early use of ceftazidime avibactam within 48 hours of infection was associated with improved clinical outcome, which underscores the importance of role of rapid diagnostic testing for early pathogen identification and early susceptibility testing. So when you are talking about monotherapy versus combination therapy, it is a meta-analysis published in 2019 by Honoraro et al. They have seen 11 retrospective studies between 2017 to 19, 396 subjects, 202 in combination, 194 in monotherapy. Study was conducted 4 in US, 3 in Spain, 1 in Italy, 1 in Saudi Arabia, and included centers from Spain, Israel, and it was a multi-center study. The 7 studies, CRE with 1 CRPA, that is carbapenem resistant Pseudomonas aeruginosa, and 3 were both the organisms. Percent of the patients admitted to intensive care unit ranged from 12.5 to 65%. 5 studies evaluated in hospital modality, 4 studies evaluated 30-day mortality, and 2 studies evaluated 90-day mortality. And definition of microbiological outcomes were different between different studies. So what are the results? The antibiotics most frequently used in combination with ceftazidime avibactam include colistin, tigecycline, aminoglycoside, fosfomycin, and ciprofloxacin. Median duration of the treatment ranges from 13 to 21 days. Mechanism of resistance: 198 patients in 6 studies had a KPC. 102 patients in 5 studies had OXA48 producing strain. 96 were unknown. What is the limitation? It is a small sample size study. Retrospective data and outcomes definition is varied. So use of ceftazidime avibactam in monotherapy or in combination therapy for infections due to CRE and CRPH could show a similar effect on mortality and microbiological cure rates. When ceftazidime avibactam is compared with others, when it is compared to colistin, it is a prospective multi-center cohort. 137 patients with CRE, 38 received ceftazidime avibactam as a monotherapy, while 99 received colistin first as a monotherapy. Baseline characteristics were similar, and types of CRE infection included respiratory tract infection and urinary tract infection, and pathogens included Klebsiella pneumoniae and Enterobacteriaceae. So the death rate evaluated at 30 days therapy: 3 out of 38 patients, that is 8% in ceftazidime avibactam group, versus 33 out of 99, that is 33% in colistin group. Clinical outcomes were better in patients who were treated first with ceftazidime avibactam rather than colistin. And the use of ceftazidime avibactam was associated with improved clinical outcome, especially decreased all-cause hospital mortality rate and improved benefit-risk outcomes. Ceftazidime avibactam, particularly in Pseudomonas. The outcomes in patients with Pseudomonas: the study by Vena in 2020, Italy, infections other than CR Enterobacteriaceae. 41 patients received 72 hours of ceftazidime avibactam for GNB nosocomial pneumonia. Pseudomonas in 33% patients. All MDR isolates, combination therapy in 80% of patients. They had a colistin, aminoglycosides, and carbapenems. Clinical success at the end of the follow-up period was 95%. No genotyping was done. Then Santvenza 2018, infection other than Klebsiella. 10 patients received ceftazidime avibactam, 46% had a pneumonia. Total 21 isolates were seen, 8 isolates of Pseudomonas, 16 palomicrobial, and median MIC was 1.5. 50% received targeted combination therapy. And clinical success was 70% among these patients. Now, epithelial lung penetration, very important. Population pharmacokinetic modeling of ceftazidime avibactam in plasma and epithelial lining fluid of healthy volunteers. Compartmental modeling analysis showed that ELF penetration of both ceftazidime and avibactam was greater than previously calculated at plasma concentration relevant for efficacy, that is 8 mg per liter for ceftazidime and 1 mg for avibactam. The ELF exposure for both the drugs exceeded their levels required for efficacy in plasma. In guidelines also, when you see complicated intra-abdominal infections, the guideline by Surgical Infectious Society consider use of ceftazidime avibactam plus metronidazole as an option for initial therapy of grade 2A, but reserves the regimen primarily for higher risk patient strongly suspected to be infected with Klebsiella pneumonia, carbapenem producing Enterobacteriaceae, for which other agents are not been suitable. NICE guideline in 2019 mentions one of the first choice of intravenous antibiotics if severe symptoms or signs at the risk of resistance. In Spanish Society and British Society also shows that in case of infective foci, intra-abdominal urinary tract or lung, the high bacterial load beta-lactam agent different from one used in last 90 days should be used, and ceftazidime avibactam being an alternative choice along with the ceftriaxone tazobactam. So what is the implication of the real world evidence? Effective treatment should be administered as soon as possible, and there is an increasing need for rapid diagnostic testing. So lack of widespread laboratory technology and older methods will take a longer time, so we'll need an agent which can be used empirically. So in clinical practice, one of the most important addition to the armamentarium for GN infections, one of the first antibiotics that targets OXA and KPC. Post-market reports reflecting real-life uses are encouraging in terms of safety, clinical response, and survival. Efficacy compared to colistin better with 64% probability of better outcome, and early use has been associated with better outcome. Stewardship, use of ceftazidime avibactam in clinical practice requires high levels of antibacterial stewardship. Stewardship teams are tasked with minimizing barriers to utilization, but must also careful not to promote overuse. Minimizing barrier will ensure that these agents can be appropriately used when needed. Institutions with particularly high rates of CRE, testing of ceftazidime avibactam susceptibility for organisms identified as carbapenem resistant should be considered to further reduce time to susceptibility information. Protecting the use of ceftazidime avibactam will help mitigate development of resistance and maintain their use as CRE active agents as long as possible. And development of criteria for use or a system of protected use is essential to make sure antibiotic is safeguarded. The prerequisite conditions for selecting monotherapy as the definitive treatment for infections caused by extensively drug-resistant drugs, you should have some patient parameters, hospital parameters, antibiotic parameters, and pathogen parameters. So you should consider all these factors before considering this drug as a monotherapy. And you should have a local antibiogram for this. So as I say, common drugs, if required, can be selected based on the antibiogram and required PKPD parameters for infectious focus. So what is summary? Ceftazidime avibactam has shown a good efficacy in real-world studies for carbapenem-resistant Enterobacteriaceae and MDR pseudomonas. It has resulted in a better outcome as compared to colistin in CRE, and early use is associated with better outcomes, and good antimicrobial stewardship practices will be required. Thank you. Thank you very much.
Thank you, Dr. Kapil, for your lecture on ceftazidime avibactam. And if the time permits, we will take few questions at the end of the session with all the four speakers. Now, moving on to next topic for today, and that is the tailoring antimicrobial therapy. And the speaker is Dr. Mohan Gurjar, who is the additional professor, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. So over to Dr. Mohan Gurjar.
Good day. I hope that at the end of this talk, you will be having a better insight about pharmacokinetics and pharmacodynamics of commonly used antifungals in ICU patients. In critically ill patients, we use antifungal either as a prophylactic or as empirical use, mainly on the basis of clinical scenario, or as a preemptive. Along with clinical scenario, there was evidence of laboratory as well as some imaging for fungal infection. Or we use antifungal as a definitive targeted therapy on the basis of microbiological confirmed report in appropriate clinical background. While we deciding antifungal use in critically ill patient, we think about appropriate drug, possibility of kind of fungal infection, as well as underlying pathophysiological condition of the patient. To achieve the goal of optimizing antifungal therapy, on the one side, we have to see various aspects, including the kind of fungus, where it is, site of infection, and once we decided to use some antifungal, how to give it in the best way. Along with, of course, we should be aware about organ dysfunction in that particular patient. On the other hand, we need to ask ourselves, is there really need? Cost, because these antifungal therapies most of the time are having high price. Think about drug related toxicity and their interaction with other concurrent use of drugs. Amphotericin B, this molecule has a broadest antifungal spectrum. It covers Aspergillus, Candida, Cryptococcus, Mucor species. Its best killing property could be achieved by highest concentration above the MIC level. So should we give it a bolus? It's not easy. What we see, the drug pharmacokinetics, the drug kinetics in the central compartment, it reaches to the peak level, then gradually it decreases because of ongoing metabolism, moving to other compartment. So drug concentration in the blood vessels, it is not always correlated drug concentration in the tissue. It may be lower than central compartment, or the drug concentration in the tissue could be higher than the plasma after the redistribution, or it can be the same as in the plasma after some point of time. Researchers have identified to look amphotericin concentration in the various tissues. So they are not always the similar. Few organs have a good amphotericin concentration, few have a less, few did not have a very good concentration. Amphotericin B is very good concentration achievable in some organs like liver, spleen, followed by lung and kidney, followed by heart and the brain. Being a drug concentration dependent killing, should we use as a bolus or should we use a continuous infusion? We have to make balance between both efficacy and nephrotoxicity, because it has been observed if we give in the brief period of time, means as a bolus, there is a higher probability of nephrotoxicity. So guidelines suggest give the amphotericin B around the 4 to 6 hour duration. Both true for non-lipid formulation as well as lipid formulation. If I summarize, amphotericin B has a broadest antifungal spectrum, drug site penetration in the various tissues are decent, mainly highest in the liver and the spleen, followed by lung and kidney, followed by heart and the brain. For non-lipid, the drug dosing is the 0.6 to 1 milligram per kg once daily. For the lipid formulation, need to give in between 3 to 5 milligram per kg daily. We have to use as a prolonged infusion 4 to 6 hours. In cases of renal impairment, we have to avoid the amphotericin B being a nephrotoxic, but if case you decide as a risk benefit, there is no dose modification. It's true for both crystalline as well as lipid formulation. In fact, in case of end-stage renal disease, you could use your crystalline amphotericin B or amphotericin B deoxycholate. It has a toxicity during the infusion itself called as infusion-related adverse event along with the nephrotoxicity. Lipid formulation, of course, has a very high cost in comparison to non-lipid formulation, around 40 to 50 times higher cost. Fluconazole, Another very commonly used in critical ill patients. It has antifungal spectrum covering the Candida and Cryptococcus, but it is not active against Aspergillus or Mucor. It has a very good tissue concentration. Almost all organ has a good concentration of fluconazole. It needs loading dose 12 milligram per kg. In adult can give easily 800 milligram on day 1, followed by 6 milligram per kg in adult 400 milligram daily. In cases of renal dysfunction, you have to consider to reduce the dose of fluconazole. If the patient on the continuous renal replacement therapy, it needed higher dose. Fluconazole causes hepatotoxicity. It causes QTc prolongation, some of the patient. Being a strong inhibitor of CYP3A4 and CYP2C9 enzymes, it increases the drug level or their effects of especially cyclosporin A, tacrolimus, commonly being used as an immunosuppressant in post-transplant patients. Effect of the warfarin increases, phenytoin and midazolam effect also increases if we use the fluconazole. Voriconazole, another molecule commonly being used. It has an advantage over fluconazole that it also covers Aspergillus. Target site penetration is good in almost all the organs. For loading dose, we have to consider 6 milligram per kg in adult, 400 milligram every 12 hourly on day 1, followed by maintenance of 4 milligram per kg that comes in the adult as around 200 milligram every 12 hourly. For this molecule, there is a strong recommendation of using therapeutic drug monitoring because metabolism of this drug is affected by various factors. In cases of renal impairment, there is no need for dose modifications. Of course, consider to switch over the route from intravenous to oral. In cases of hepatic impairment, consider to decrease the dose of voriconazole. It also do QTc prolongation in some of the patients. Because of solvent vehicle in the intravenous formulation, there is a nephrotoxicity, not per se because of voriconazole molecule. So in cases of ongoing renal insult, consider from the intravenous to oral route. Being a strong inhibitor of CYP2C9 and CYP3A4 substrate, it increases the drug level or effect of cyclosporin A, tacrolimus, warfarin, midazolam, opioids, and commonly used omeprazole. So these drugs has to be considered to decrease in their doses. On the other hand, the drugs which induces the enzyme like rifampicin, carbamazepine, they lead to the drug concentration of voriconazole. So in cases where the ongoing concurrent use of rifampicin or carbamazepine, maybe we need to increase the dosage of voriconazole. Posaconazole, another molecule available in India last few years. It has advantage over fluconazole and voriconazole that it also covers Mucor species. But it has a low penetration in the brain and the CSF. It is available as oral suspension, tablet or intravenous formulation. For oral suspension, need to give in 200 every 6 hourly on day 1, followed by 200 milligram every 8 hourly. For Tablet and intravenous formulation. Loading considered to give 300 mg 12 hourly, followed by 300 mg daily as a maintenance. Societies also recommend therapeutic drug monitoring in cases of posaconazole, especially when you are using the oral suspension. The absorption could be affected by the fat content. Absorption is better with higher fat content, so much so that it can affect almost 50% of plasma concentration just because of availability of fat and the good absorption. So you need fat along with oral suspension. In cases of renal impairment, no dose modification. Of course, consider change intravenous formulation to oral formulation. In hepatic impairment, no dose modification for posaconazole. Again, hepatotoxic, chances of QTc prolongation. Being a strong inhibitor of CYP3A4, it increases drug level effects of cyclosporin A, tacrolimus, and midazolam. While phenytoin could reduce the drug concentration of the posaconazole. Another recently launched in India is isavuconazole. It has the advantage over other azoles because it also covers aspergillus as well as mucor. Also has a good drug concentration in the CSF. But for other organ tissues, there is less information available for this new molecule. For loading, you have to give 2 days higher dose, that is a 200 mg every 8 hourly, and for maintenance 200 mg daily. In cases of renal and hepatic impairment, no need for dose modification. Isavuconazole is a hepatotoxic drug, and paradoxically, it reduces the QTc interval. Being a moderate inhibitor of CYP3A4, this drug could lead to increased drug level effect of cyclosporin A, tacrolimus, midazolam, like other azoles, while concurrent use of rifampicin, carbamazepine, and barbiturates, in fact, they could lead to the decrease in the drug concentration of isavuconazole. Echinocandins, 3 drugs commonly used, available easily: caspofungin, anidulafungin, micafungin. They have a good action against Candida and Aspergillus, but not having antifungal activity against Cryptococcus or mucor. These drugs reaches in low concentration in the brain. They need a loading dose followed by the maintenance, like for caspofungin, need 70 mg on day 1 followed by 50 mg daily. Anidulafungin 200 mg on day 1 followed by 100 mg daily. For micafungin, no need for extra dose on day 1. It is 100 mg on day 1 as well as in subsequent days. In cases of renal impairment, no dose modifications for echinocandins required. While hepatic impairment, anidulafungin, no dose modification. Caspofungin has to be reduced in cases of severe liver disease, while micafungin has to be avoided in cases of hepatic impairment. They are hepatotoxic. For drug-drug interaction, not much known about clinical significance with other available drugs commonly used in critically ill patients. In summary, for tailoring antifungal therapy, we should consider the type of fungus, where they are in the human body, and we should be aware how to maximize fungus killing. Also, optimize the drug dosing in view of underlying organ dysfunction. On the other hand, always review, is there really need for this antifungal therapy? Their possible toxicities, look for that, and must be aware about drug-drug interaction with ongoing concurrent drugs in your critically ill patients. There are some references available. Detailed review about pharmacokinetics of antifungal therapy, tissue penetration of antifungal agents. Any question?
Thank you all. Thank you, Dr. Ritesh. Thank you, Dr. Anand. Thank you, Dr. Kapil. And lastly, Dr. Mohan Guja. I think we are shooting ahead of the time. I think one question to Dr. Ritesh Shah from my side is, see, we are still going on into the COVID era, and I think we have seen in our setup that uh, pre-COVID era MRSA was not that prominent. But do you see the increase of MRSA in your setup and post-COVID, and this drug will help in those conditions?
Yeah, that's a nice question. See, actually, before COVID era, we were not used to kind of look at what exactly MRSA because of the broad spectrum covered antibiotic already available. But COVID has taught us, multiple organisms, not only MRSA, but a variety of organisms that we see very, very, new and first time probably sometimes we are listening those bugs. So having said that, we have not seen a bunch of patients that were given steroids, and that is probably one of the culprit with the background of all other premorbidity that increase incidence of MRS, and that's how we need to look at this kind of drug. So definitely we are seeing slight increase in the incidence of MRSA, and see MRSA even some increase may lead to disaster in subsequent time. So it becomes your ICU bug very, very routinely like Acinetobacter. So definite increase in incidence of MRSA as compared to pre-COVID era. Not only MRSA, but as I said, a variety of bugs. So probably this drug having a multiple, broader spectrum, when we don't know. So it may be in future and a kind of an empiric antibiotic if we want to cover all. Having said that, so far there is no major evidence. I have just narrated the characteristics which are available, not studied face to face in a clinical randomized trial so far, but maybe just available. Let's see what subsequent time teaches us.
Yeah. Look at our setup now. We have seen, actually Dr. Kapil is not there. I was about to ask him, because now we see that Klebsiella has gone resistant to Avicas also. Ceftazine, Avibactam also combination using the Aztreonam also, and we find that that they are getting multi-drug resistance. So I don't know whether all the three antibiotics which has been antifungals also has been mentioned, whether we will be able, the efficacy is already going on the downside, whether we will be able to use that post-COVID era. I don't know. It's just a prediction. And what's your take on that?
So I think you are absolutely right. What is see, it's easy to pen down any antibiotic, and unfortunately, I'm sorry to say, but it's kind of dysregulated use. I would use the term rather than misuse and overuse. It's a dysregulated use. Dysregulation, we are not answerable to regulation or legal regulation. We are answerable to ourselves. So the way to go is a stewardship at your own level. Even if you are having 2-bedded ICU or the 200-bedded ICU, doesn't matter much. But what is the way to go is a stewardship. Audit every 2 to 3 months that what's your bugs, what's your drugs, and what's
the efficacy as well as safety and your resistant pattern. So all 5 factors, if you study in a periodic manner, probably we may get away to use such a wonderful antibiotic unnecessarily rather than, indicated.
Okay, thank you all. And I think we will move ahead to next sessions, the pro and con debate. I think Dr. Alok Soin was about to join, but he's not there. So I'm just introducing for this pro and con debate. The topic is hydrocortisone has no proven role in non-endocrine shock. For the pro, I invite Dr. Jojo Kurian, who is the lead consultant intensivist at Medical Trust Hospital. And over to Dr. Jojo. And for the con debate, it will be con debate will be with Dr. Sudha Krishna Malik, who is consultant at Narayana Hridayalaya Hospital, Kolkata. So over to Dr. Jojo.
Good afternoon. I'm Dr. Jojo, and in this debate session, I'm going to say that hydrocortisone has no proven role in non-endocrine shock. All of us know that corticosteroids improve the blood pressure across the spectrum of shock, but they are very potent agents which have a lot of other effects. And when you take the net effect, I'm going to argue that there is no benefit. Let's look at the different types of shock based on the pathophysiology. There is no evidence that hypovolemia can be treated with steroids. You would treat hypovolemia with either volume or blood. So is the case for obstructive shock. When it comes to cardiogenic shock, most of them, MI, cardiac failure, arrhythmias, valvular disease, no role for steroids. There used to be a question about myocarditis, especially viral myocarditis, and there's a lot of literature on it. And the best available evidence now says do not use corticosteroids. So no evidence for cardiogenic shock as well. The real point of contention, however, for this debate is going to be the role in distributive shock. I will not be talking about the endocrine causes of distributive shock. Let's take toxins and medications producing shock, vasodilatory shock. Absolutely no evidence. How about neurogenic shock because of spinal cord injury? Again, there have been a lot of literature, and the World Federation of Neurosurgeons guidance in 2020 has concluded clearly that corticosteroids are not indicated in the acute phase of spinal cord injury. No role in spinal cord injury also. How about anaphylaxis? This is a systematic review of evidence which looked at the pharmacological management of anaphylaxis and found that only epinephrine was associated with a lowering of mortality. And when glucocorticoids were administered, it actually lowered the odds of the patient getting epinephrine because people were a little hesitant to give epinephrine. It also did not reduce biphasic response in anaphylaxis or reduce readmissions. Not only was there a lack of a benefit, there was also a signal for harm. In this double-blind, placebo-controlled RCT, which looked at anaphylaxis induced by snake venom prospectively, only adrenaline was effective, and combining corticosteroid with adrenaline actually reduced the positive effect of the drug of choice. Moreover, deaths were more common in the group which received corticosteroids. Based on all this, all major professional organizations have made their recommendation that there is no benefit. This is a guidance paper from 2020 saying that there is no benefit for corticosteroids in the management of anaphylactic shock, except perhaps in somebody who is also having a bronchospasm, but not for shock. Now we come to the main bone of contention, sepsis. Before I look at the evidence, let's look at the logic or the concept of why corticosteroids are thought to be beneficial in sepsis, the concept of relative adrenal insufficiency. The idea was that there is a relative deficiency of cortisol in sepsis, and which could be identified by a corticotropin stimulation test. And people who do not respond to corticotropin by an increase in cortisol are having relative insufficiency, also called SIRSI, and these are the people who would benefit with corticosteroids. This was elegantly shown in the landmark trial by Anani, but subsequent trials, all of them miserably failed to show this. This is data from the Corticus trial, and you can see the response to steroids in the corticotropin responders and non-responders, absolutely no difference. This is the same even in the adrenal trial. In the adrenal trial, in addition to that, they went ahead and did a nested cohort study where they looked at the baseline cortisol levels and showed that there is no effect of the baseline cortisol on the response to hydrocortisone in septic shock. And some proponents of corticosteroids might now argue that the total cortisol is not what matters. The free cortisol is active, and there is a lot of pharmacokinetic changes in the binding proteins and so on and so forth in sepsis. True, they did look at free cortisol levels, and again, there was zero association between that and the effect of corticosteroids on mortality and other significant outcomes. So this is a flawed concept. Another major misconcept that we sort of propagate in critical care is the idea of the so-called physiological doses of corticosteroid. Agreed that 200 milligram per day is much less and much more physiological than the super physiological doses used earlier. But we need to remember that in totally adrenal suppressed patients, the usual replacement dose of corticosteroid hydrocortisone is about 25 to 30 milligrams per day. 200 milligrams is almost 8 times that, not physiologically. And at those kind of doses, the effects of these potent agents is not completely predictable because there is a lot of polymorphisms happening at the level of different ways paths at which the corticosteroids act, including the receptor at the level of transcription, post-transcriptional modification, and also at the site of rapid action of corticosteroids and non-nuclear actions mediated by the kinases. There's a lot of polymorphisms and heterogeneity, and the effect of cortisol cannot be completely predicted. And this is why if you take the evidence now in septic shock, there is no consistent effect on mortality. These are the major trials which looked at septic shock, and the adrenal and approaches trials are the most recent. And except for the Anani trial in 2002 and the approaches trial, there has not been a statistically significant or significant improvement in mortality. Now, the only trial which was powered to look at mortality was adrenal, which did not show an effect on mortality. Let us actually focus on the trials that did show a benefit. The Anani trial, which is the trial which drives the mortality benefit signal in most of the meta-analysis. This is the table from this paper. The 28-day mortality was statistically significant and different. However, the problem is that this is an adjusted odds ratio. If you do a non-adjusted analysis, 73 for 115 and 60 for 114, like in the table, you can see it becomes statistically not valid. So this primary paper itself is suspect. How about the approaches trial? Look at the fragility index. It's 3, which means that the chance that this could be by fluke is quite high. And you must remember that if you look at the interim analysis of the larger trial, the adrenal trial during second interim analysis, it had almost the same number as the entire approaches trial. And at that point, it did show a benefit, but when they continued recruitment and at the end, when they had enough numbers to actually power the difference in mortality, there was no difference. So probably this could be a statistical fluke. Now, you could argue that leave mortality alone. There were other patient-centric benefits like ventilator days, ICU days, which were reduced. Agreed. If you look at the adrenal trial, the mechanical ventilation days were shorter, but ventilator-free days were not. And there was no rate reduction in the rate of recurrent mechanical ventilation. ICU days were less. However, the ICU-free days in hospital and outside hospital were not reduced. These again raise questions whether these are actually relevant. There is absolutely no controversy that corticosteroids improve the blood pressure, very modestly at that, about 5 to 6 millimeters of mercury. And it actually reduces the patient's vasopressor dependence earlier, but it did not translate into benefit. So if there was indeed a benefit that the patients were weaned off vasopressors early, their splanchnic perfusion would improve, their liver functions would improve, their renal functions would improve, and their RRT requirements should come down. None of these were seen in the RCTs, and that again raises questions. This is the latest guideline which have looked at all the published trials so far, and which tells us pragmatically that if you treat 1,000 patients with septic shock with corticosteroids, you could reduce maybe 18 deaths at the cost of 53 more survivors having severe neuromuscular weakness. And it goes on to say that fully informed patients who value avoiding death over the quality of life and function would likely to choose corticosteroids. So the question is really whether you want to be just not dead or really alive. There is not just an absence of benefit. There are a lot of papers which actually signal harm. This is from the Surviving Sepsis database, a really large database, I should say, around 28,000 patients. And in patients who were eligible for steroids because of septic shock, they compared the mortality between those who really got steroids and those who did not. And the mortality was higher in those who were actually treated with steroids. In cancer patients, the study showed that there was an increase in secondary infections, almost twice the level, 44 versus 27%. Not only was the infection incidence high, those who actually developed secondary infections, the mortality was also doubled. 62% versus 37% who did not develop secondary infections. Cirrhotic patients with septic shock, there was a relative risk of three times the chance of clinically significant GI bleed. Pediatric sepsis, hydrocortisone has been shown to be associated with a longer duration of multi-organ dysfunction. Again, this paper looked at different endotypes based on the genomic studies and on the RNA response to hydrocortisone, and they classified patients on the basis of this response into different endotypes, and they showed that endotype A patients had actually a higher mortality if they were actually treated with hydrocortisone, a clear signal for harm in selected patients. So sepsis also, there is no clear go-ahead for corticosteroids. We should proceed with extreme caution. So to wind up, there is no role of overall benefit in unselected patients with septic shock with corticosteroids. Thank you. We can start sharing, Dr. Sudakshina.
Yes. Share screen again?
Yes.
Okay. Got it. Thank you, Dr. Kurian. And yes. Hello. My slides are not moving. My slides are not progressing. Yes, got it. Right. Thank you. I'm set. Thank you, Dr. Kurian. So just introduce myself. I'm Sudakshina, and I work as a consultant in critical care at Narayanan Rudalaya Hospital in Calcutta. So the debate topic is hydrocortisone has no proven role in non-endocrine shock, and I'm speaking against the motion. So that's exactly what I'm trying to prove, that hydrocortisone does have a role in non-endocrine shock. So just a quick recap of hydrocortisone. I'll just highlight on the points that are relevant for us in shock. So hydrocortisone has effects on the cardiovascular system. It enhances, just a second. Yes, it enhances vascular reactivity to other vasoactive substances and helps the nervous system maintain blood pressure. Yes, it's also has a use in stress response as an anti-inflammatory and immunosuppressive. It decreases release of vasoactive and chemoattractive factors. It reduces extravasation of leukocytes and also reduces fibrosis, thus helping in healing. So a quick recap of the different types of shock. Either there's not enough blood to go around, or there's inadequate pump function. Not enough blood can be absolute, that's hypovolemic shock, or relative, that's distributive shock. Inadequate pump function can be either intrinsic to the heart, that's cardiogenic, or extrinsic, that's obstructive shock. Now, hypovolemic shock can be either fluid loss or blood loss. Distributive, we have septic, anaphylactic, neurogenic, and hypoadrenal. Cardiogenic can be either global or regional wall motion abnormalities, and obstructive, as we know, are the tamponade, pulmonary embolism, and tension pneumothorax. Now, I'm going to just touch on most of these types of shock, all excepting hypoadrenal, which is precluded by our topic of debate. So here the question, this is a table showing, basically I'll just quickly touch upon the cardiogenic and obstructive shock. We don't have any textbook evidence of usage of steroids in either cardiogenic or obstructive shock. So our bone of contention today is about hypovolemic and distributive shock. Distributive, all excepting obviously hypoadrenal. Now, in hypovolemic shock, very early in the 1950s and 60s, there have been some studies using high-dose steroids in hypovolemic shock. But gradually, this practice got phased out after the development and basically the discovery of good fluid resuscitation and good blood transfusion practices. So as far as we are concerned, the hypovolemic shock, steroids and hypovolemic shock is also out. Now, as regards neurogenic shock, as has been pointed out by Dr. Kurian, neurogenic shock per se is supposed to be treated by fluid loading and vasopressors. Acute spinal cord injury, yes, doesn't always lead to neurogenic shock. May be treated by, there are studies which have shown they may be treated by high-dose steroids, but there's still a controversy related to that, and definitely not hydrocortisone. So I'll keep that out. So we are left with anaphylactic and septic shock. I'll be touching on these two primarily. I'll start with anaphylactic shock. Dr. Kurian has actually touched upon this. So very quick, in the last decade, there has been one Cochrane review and few guidelines. But the summary of these, the guidelines basically in 2013, 2014, and 2015. So the summary is that steroids are not the primary or the initial treatment in the acute phase of anaphylaxis, where you're supposed to give epinephrine, and fluid loading. However, in secondary, the secondary stage, to prevent the biphasic anaphylaxis, it might be used. This information, the drugs used and the doses are mostly extrapolated from asthma. The onset takes several hours, so it's not exactly useful in the acute stages, and it's definitely not meant to be initial treatment. And it should be stopped once the shock is reversed, which usually takes about 1 to 2 days. The onset of action, there is a bit of a controversy, and the recent guideline which came out last year, which was a systematic review and grade analysis, that says the timing is about 4 to 6 hours. But in this 2020 guideline, they've actually they put an end to the concept of glucocorticoids in anaphylaxis, I have to admit. And the other effective uses are not in anaphylactic shock, at least. So even anaphylactic shock is out. So as far as I am concerned, so this is one thing. This is a kind of old study in 2007, but all the different countries which have guidelines on anaphylactic shock, Australia and USA don't even recommend its use, and the few countries that do recommend use of hydrocortisone, they're mostly old data. The latest, the latest being 2005, and the strength of evidence is not mentioned. So as I said, the anaphylactic shock use of hydrocortisone is out. So I'm left basically with only septic shock. Now in septic shock, the studies, the evidence can actually be divided into two phases. 1995 seems to be a watershed year for the use of steroids in septic shock. How so? Let's look at the evidence. So studies done till 1995 used steroids, mostly methylprednisolone or dexamethasone. They were high dose and short duration steroids. And there were quite a few starting from the mid 1970s to 1995. In these 20 years, we have these few studies. And in 1995, there were 2 meta-analyses which drastically changed the way people were using and looking at steroids in shock. And we'll see how in the next few slides. So the studies done after 1995 and starting as early as the last century, they used hydrocortisone. They used it in low doses. They used it for at least 3 to 7 days, a prolonged use and a slow taper. And these studies are the ones which, the ones in this century we are more familiar with. There were 2 studies by Bolat and Brigel at the end of the last century, and then Anand's famous study, the Corticus, a few years later, another systematic review by Anand. And in this last decade, the Hypres study, the Marek study, which gave us the Marek protocol, and the Adrenal and the Approaches, which were actually published in the same issue of NEJM back to back. Now let's see what they tell us. So in 1976, Schumer did a study, which was both a prospective and retrospective study, used dexamethasone, methylprednisolone, and saline. It was a randomized trial, and the overall mortality was significantly less in the steroid groups. So it was a hopeful study. Almost 10 years later, Charles Sprung and his group did a study in septic shock patients, again with the same drugs. The shock reversal occurred in steroid-treated patients, especially those who were treated early with steroids. However, later on in the hospital course, more patients in the steroid group died. So the evidence is already getting a bit dim here. Then Roger Bone, in a few years later, this is the same Roger Bone of the sepsis definitions fame. He did a randomized trial with high-dose methylprednisolone, but found no significant differences in shock reversal or mortality, and more infections actually in the steroid group. In the same years, a veterans study group also did an RCT, and which did not show any survival benefit in the treatment arm. Now, almost 10 years later came these 2 meta-analyses. One was by Leffring from 49 publications and 10 prospective randomized trials. They did not show any benefit with steroids. There was a statistically non-significant benefit in gram-negative sepsis, but there was no difference with high and low dose steroid use. And Cronin, in the same year, did another meta-analysis of which 9 RCTs were considered. Steroids were shown to increase mortality in overwhelming infection. There was no benefit in the septic shock subgroup. And there was a trend towards increased mortality and secondary infection arising out of steroid use. So again, we're not very hopeful here. But post-1995, we see a set of studies which actually did show some benefit. Now let's see what benefit they had. So in 1998 and 1999, Bolat and Brigel did 2 almost similar studies with hydrocortisone in septic shock patients, and they were fluid resuscitated and were on vasopressors. Shock reversal in Bolat's study was found to be higher, but no mortality benefit. And in Brigel's study, which was published the next year, septic shock patients again were selected, those who were on vasopressors. And the same finding was obtained that the duration of vasopressors was decreased. Time to cessation was statistically significant. Vasopressor suppression, cessation was significantly reduced in the treatment arm. However, as in the previous study, there was no significant mortality difference. Now, a few years later, next came Anand's landmark study. It was an RCT which actually pitted hydrocortisone and fludrocortisone against placebo. And it was shown to lower mortality in septic shock. What they did was that they did a short cosentropin test, and almost 75% of patients were non-responders, and surprisingly, the mortality benefit was found in that group who were non-responders, and there was a lower mortality in this study. So things again began to look hopeful. Now, just a few years later came Corticus. It was another multicenter RCT, and here the same thing. Now the study group was beginning to look like the type of patients whom we would give steroids now according to our surviving sepsis guidelines. So patients who are adequately fluid resuscitated, in septic shock, on vasopressors, and they receive low-dose hydrocortisone with a slow taper, and they also did a corticotropin test, and about half of them responded, half of them did not. The death at day 28 was studied. No mortality difference was found, though shock reversal was earlier in the treatment term, but superinfection was found to be more. Now, the very next year, Anand did a systematic review, and there were 20 studies in all, and they looked into risk, benefit, dose, and duration of steroids in both severe sepsis. If you remember, the severe sepsis definition was still in vogue at that time, and septic shock. Again, there was no difference in 28-day mortality, although in the patients receiving low-dose steroids, they did find a mortality difference. Again, shock reversal and ICU length of stay was less. Shock reversal was quicker and ICU length of stay was less in the treatment arm. And the dreaded complications of steroids, as GI bleed, secondary infection, and neuromuscular weakness, was about same in both the arms. However, hyperglycemia and hyponatremia were found to be more in the treatment arm. And that's an expected side effect of steroid hydrocortisone use. Now we come to the last decade. There was HYPRESS. HYPRESS was trying to look at preventing septic shock in severe sepsis patients. They came up with a negative study. The next year, Paul Marek did a retrospective before and after study, and he used a combination of vitamin C, thiamine, and hydrocortisone. The results were outstanding. There was mortality benefit, less of a score, no organ dysfunction, and all the patients came off vasopressors. However, we still, though it's been adopted worldwide, this regimen, but we still don't know whether it was the vitamin C or the thiamine or the hydrocortisone or all three put together that actually helped the patients. Now, next came the adrenal and the approaches trial. So adrenal came from Bala Venkatesh's group. It was a huge randomized controlled trial with lots of patients, but they were looking at septic shock ventilated patients only. Just hold on to that thought. We'll come to it in approaches again. They used low-dose hydrocortisone versus placebo. However, they found no statistically significant difference between the two groups. So in the last few years, this was the major damper in the steroid trials. Now, approaches, the way you turn the page and you see approaches. So approaches again was an RCT. This was by the French group, the European group, studying both. Again, they looked at hydrocortisone and fludrocortisone versus placebo, and their primary outcome was 90-day all-cause mortality, which was lower. Also, ICU length of ICU mortality, hospital mortality, and 180-day mortality was lower. However, 28-day mortality was not lower. The vasopressor-free and organ failure-free days were significantly lower, but the ventilator-free days were not. And this is something that tallied with Bala Venkatesh's study, the adrenal. We don't know why that happened, but I think that would need some more investigation, but not exactly what we're looking at right now. Only hyperglycemia was the more common adverse effect in the approaches trial. So that's about the end of the study still date. Now, if we come to the guidelines, the Surviving Sepsis Campaign guidelines, and I'm going to look at all of them one after the other. So the usage of hydrocortisone in doses of 200 to 300 milligram per day for 7 days in divided doses or by continuous infusion recommended in patients with septic shock, as we know, who despite fluid replacement are requiring vasopressors. Doses of more than 300 milligram are not recommended, and if there's no shock, don't use corticosteroids unless this patient previously was on steroids. But that is going into hypoadrenalism, and I'm not getting into that. So the next Surviving Sepsis Campaign. So again, almost the same group of patients. Those have been in shocks, fluid resuscitated, still on vasopressors. They suggested that you should not wait for, and this, if we see, was after the was after the Anand study.
Krishna, I'm told by the organizers to tell you that your time is up.
Yes, sir. Just a couple of slides more. I'll quickly go through this. Suggests that ACTH stimulation test should not be used They should not receive dexamethasone if hydrocortisone is available, but if dexamethasone is used, then you could think of using fludrocortisone also, because it doesn't have a mineralocorticoid effect. Wean the patients as soon as you're off vasopressors. Not more than 300 milligrams should not be used. And again, if there's no shock, should not use steroids, excepting if it's for replacement. Now 12, almost same recommendations. The maximum dose here was cut down to 200 mg, not to use ACTH simulation test, and tapered it off as soon as possible after your vasopressors are out. Corticosteroids should not, no shock, no corticosteroids, and they were recommended using infusions. 16, almost the same, and COVID guideline, or last year's guidelines in COVID, they gave a COVID-19 guidelines about the same. And this is just my last slide. The critical illness related corticosteroid insufficiency, they give the same recommendations, the only difference being they've hitched up the maximum dose to 400 milligram. So where do we stand now? I'm coming back to this slide which you've seen previously. So we're not using it cardiogenic or obstructive or hypovolemic. And in distributic shock, anaphylactic, there's a yes, no, though initially there was a tendency to use it for biphasic anaphylaxis, but probably no after last year's guidelines. And in septic shock, yes, I would still use it at least. And I think I'll rest my case now. Thank you. Over to you, Dr. Kurian.
Please stop sharing screen.
Yes, sir.
Okay, so I will do a quick rebuttal because we have used up all our time. Thank you, Dr. Sudakshina. You have made a convincing argument regarding the use of hydrocortisone. My only rebuttal is that even though there are signals of benefit, there are adequate signals of harm too. And when we don't know what exactly is going to happen to the patient, it's our duty not to actually harm. First, do no harm. And I rest my case. Over to you, Dr. Sudakshina.
Yes. For me, Dr. Kurian, thank you for your rebuttal. For me, I don't think that my debate here is whether I should use steroids. Rather, what steroid to use, in what dose, how long to use it, when to taper, how to taper, what to monitor, hyperglycemia being the main. We use infusions, though there has been a comeback to using boluses 50 QDS again. So that is my worry at this point. I would definitely give steroids to my patient in septic shock who is fluid resuscitated and is still on vasopressors and not coming off. Thank you. Over back to you, Dr. Kurian.
Thank you. I concede that I would do the same, Dr. Sudakshina. Over to you.
Thank you, Dr. Kurian.
Okay, thank you all. Thank you all for this excellent lectures and pro and con debate.